organs, oral cavity, but here it will be just a brief summary. Otherwise, oral cavity, salivary glands, and maxilla, mandible diseases, they shall be covered in another chapter on head and neck pathology. So we shall see also esophagus, stomach, small bowel, appendix, inflammatory bowel disease, and the colorectal. So that's in summary what we shall cover here. So this book I was saying, which summarizes the principles of general pathology and the systemic pathology, is fundamentals of pathology, and I have shared it with you on through email together with this present. Okay, separately, but both this presentation and the book itself I sent them. So, and as I wrote in the email, you should also keep in mind that Robin's basic pathology remains the core textbook for pathology. So, looking at the anatomy of the gastrointestinal tract, and here you will also notice that in some books, gastrointestinal tract doesn't include the salivary glands, it doesn't include the liver, pancreas, and the biliary tract. In other books, they combine them in what they call alimentary tract or alimentary system or digestive system. So here we will separate them. So as I said, the salivary glands, we shall come back on them in head and neck pathology. And then there will be another presentation on the liver, pancreas, and the biliary tract. So here we will really focus on the gastrointestinal and tract and esophagus, of course, included. So these organs, they are oral organs having a lumen. They have a lumen, then the lumen has a mucosa which is epithelium. It is mostly columnar epithelium, except in mid and upper esophagus where it is squamous. Then you have a submucosa. We have apart from the mucosa, in the mucosa we have epithelium and you have the lamina propria, and we have a masseteric mucosa. All this they make up the mucosa. Then you have a submucosa and you have a muscle layer. And the muscle layer, as you saw in anatomy or histology, you saw that muscle layer, if you are given a section of the stomach and a section of the let's say intestine, you should be able to distinguish them by their muscles. So muscle layers in the intestines, they are in two layers. We have inner circular layer and there is an outer longitudinal muscle. This is longitudinal. So these two layers, they exist in intestines. When it is the stomach, there is a third layer. So they have three layers in the stomach, in masseteric propria or externa. The other one is the oblique muscle. And then you have here the tunica externa, which is serosa. It can be called serosa when we are in the stomach and the intestines because there is a peritoneum. But in the upper esophagus, it cannot be called serosa because it is not a peritoneal cavity or pleural cavity. So we have other differences as you saw. For example, if you are in the small intestines, ileum, duodenum, and jejunum, they can look the same, but there are some differences. The villi are larger in the jejunum, and the duodenum, it has some glands inside the submucosa, which is unusual. So we call them Brunner's glands. So when you see them, you know exactly that you are dealing with duodenum, not the ileum or jejunum. Of course, this day we have vascularization, the arteries and the veins and the lymphatics and so on. And you have nerves going there. So this diagram is showing the different diseases that some of these we will cover them in this presentation. For example, in esophagus, we have achalasia, we have hernia, I have a squamous carcinoma in the upper esophagus, a lower esophagus. We have a Barrett's esophagus and the adenocarcinoma, esophageal varices, and so on. In the stomach, we have a gastric ulcer, gastritis, cancers, and so a long list. A long list. So we start with the oral cavity. In the oral cavity, the first, as I said when we started in the morning, I said in most of cases, in most of organs, we have a malformation or congenital anomalies. We have inflammations, which include infections, and we have benign tumors and the malignant tumors. So here in the oral cavity, can you start with malformations? So you see this picture, cleft lip and the cleft palate. So hari nibyo bita ibibari mujya mwumva abantu baza kubaga bitwa operation smile, bakunda kuba bahari za sashika n'ahandi baza kubaga abantu bafite ibibari ku buntu. So ibibari hari ubwo ari umunwa ubusatuye, hari n'ubwo ubusatuye ahantu habiri. So this one you see that it is written unilateral. Hari bilateral ho umuntu usatuye habiri. And sometimes they will involve not only the lip but also the palate. So it will be cleft lip and the palate, like this chart. This one has both cleft. Okay, cleft. So there will be a full thickness defects in the lip or palate or both. And this is due to the failure of facial prominences to fuse. So it is said that during embryogenesis, in early pregnancy, facial prominences, one from superior and two from the sides and two from the inferior, they grow and they fuse together to form the face. So there can be a failure to some of them to fuse, which will lead to these things. So I think you have seen such people. There are a few, but they are not rare. They're not rare. Where you were born or at the university, maybe you can see someone who had his or her lip repaired, cleft lip repaired, and so on. So they usually occur together. Isolated the cleft lip or cleft palate are less common. So as you understand, the reason is developmental. So it is not acquired after birth, it is acquired in utero, and the treatment is just repairing, surgical repair. So after ulcer, this is the ulcer of the oral mucosa, and it arises in relation to stress and resolves spontaneously, but often recurs. There will be a grayish base surrounded by erythema. Erythema, it means reddish. So for example, here you see that there is somewhere a tissue here is yellowish, maybe because of pus, but around it is red. So red means erythema. So I think, as they say, they just come spontaneously. Yeah, it happens to anybody. Nta kintu cyagukomerekeje, you didn't have any viral infection, ko arizo zishobora gutuma umuntu agira nka twa vesicles and then rupture. So bikizana kandi hamara igihe ukumva ushira igihe kuma byaragiye nta nubwo wibuka ko wari ubifite. So and here this diagram is comparing this ulcer from herpetic ulcer. So this herpetic one, they are caused by herpes virus infection, and it affects the keratinized mucosa of the gingiva, the hard palate, and so on. So usually it happens when someone first you develop vesicles. Vesicles murabizi ni akantu kabyimbye gato kaba karimo fluids imbere. So nubwo biza ku munwa cyane cyane umagize umuriro, bakora ngo iyo malaria wagize malaria igapfuba bakunda kuvuga. So and you see that first of all there is that swelling, while in ulcer there is straightforward ulceration, meaning that a part of the mucosa is lost, while in herpetic ulcer there is first a swelling which is filled with fluid, then there will be ulceration of that. So that's the main difference. And usually herpetic ulcer comes into a febrile situation. So someone has a fever unexplained, or it can be explained. Those having a severe flu, severe or malaria, or any other another febrile disease. So we are talking about the oral herpes. So vesicles involving oral mucosa that rupture resulting in shallow, painful red ulcers. So usually this was due to human herpes simplex virus 1. Herpes simplex virus 1, but I should have mentioned it somewhere. Ibi byari kera, ubu byarahindutse abantu banarwaramo HSV2. So it is written that HSV1 affects the oral cavity, while HSV2 affects the genital organs, so sexually transmitted disease. But because of the changes in the behaviors of people where they do oral sex, so things have changed. So you can just have HSV2 positive in oral cavity, or HSV1 positive in the genital organs. So it happens nowadays. So primary infection happens in childhood. The lesion is healed, but virus remains dormant in ganglia in the trigeminal nerve. And I think this is general to most of viruses. Ni kimwe na Epstein-Barr virus. So when someone is infected with this virus, itanga ibimenyetso ukagira nk'umuriro igihe gito, then umubiri ukirwanaho ya virusi ikicecekera. So akenshi rero zijya kuba Epstein-Barr virus zikunda kwihisha muri epithelial cells in oropharyngeal cavity, ubundi izindi zikaba muri memory B lymphocytes. Hanyuma izi zo urabona ko zijya kuba muri ganglia. Ganglia, you know, these are large, like they are like a neuron nuclei. So these viruses will be there. So they will be reactivated because of different things. Nka virus ya Epstein-Barr ikunda kuba reactivated iyo umuntu agize ikibazo gituma immunity ijya hasi. Ishobora kuba ari severe infection, ishobora kuba yize ni malignancy, or any other reason of having immunodeficiency. And you see that for this herpes virus, the stress and the sunlight can cause the reactivation of the virus, leading to vesicles that often arise on the lips, with what is called sores. So this is considered like a banal in most of the cases. Ingene iyo cyane cyane nkuko nabivuze izo umuntu yagize umuriro cyangwa yagize stress, asanga yagize ibisebe hanyuma bikikiza, nabyo viruses basically they don't have a treatment except those affecting the liver. Others you just treat symptomatically. So Behçet syndrome, these are ulcers, but which is recurrent, and they don't involve only the oral cavity. You see on this diagram that they can involve different areas, genitals, even the eyes with uveitis. So oral ulcers, sometimes they can even affect the colon, ulcers in the colon, so they will cause hemorrhage. The reason why someone will have a bloody diarrhea. And they can also, Behçet syndrome also affect different other parts such as vessels, so causing systemic vasculitis, which is autoimmune, meaning that the antibodies produced by the body, they destroy some parts of that body. So that is Behçet syndrome. So if you have someone with oral cavity ulcers, you will have to distinguish three things: Behçet syndrome. In this case, you will also investigate genital organs, eyes, if in history they don't have bloody stools, or if they don't know, you can just request for stool examination in parasitology and so on. So that's how you can confirm Red Screwed Basset syndrome. Then another diagnosis will be ulcer itself, which doesn't have any other context. I think it will be a diagnosis by the Screwed. And then you have herpes, in which you will see if that person was having a fever. For example, you can do erythrocyte sedimentation rate to see that they have just an inflammation, a generalized inflammation in the body somewhere, and so on. So I think these are a few things you can distinguish clinically if you are thorough in your examination. So the last entity we will see on the oral cavity, it is the cancer. So it's so that we started with malformations, then inflammations, and then we go to the tumor. So benign tumors are not many. Of course, the inflammation, we have not covered many because, as I said, this chapter will come back in head and neck pathology. So squamous cell carcinoma, you remember the nomenclature of the tumors, it means it is a cancer arising from the squamous cells, squamous epithelium. So it is a malignancy arising from the cells lining the oral mucosa. And the most common cause is tobacco and alcohol use, even in our country. So now abantu tubona kenshi ariko usanga benshi bafite history of smoking. So abanywa itabi iri batumura n'ibiki byose bakunze kugira amakanseri ya larynx and lungs, ariko niyo mu kanwa bashobora kuyigira, ariko abandi bagira iyo mu kanwa cyane, abandi bajundika ibintu. Kera babaga ari abagore, sinzi niba n'abagabo bajundika, ariko kera wabonaga n'abakecuru bajundika ibintu nk'ibyo by'ibitabi. So they were causing they are risk factors to squamous cell carcinoma and oral cavity. Of course, there are the other factors. Kurya ibintu byose bishobora gukora irritation mu kanwa, ibintu bishyushye cyane, ibintu bishyushye cyane nabyo, it can be a risk factor to that. So the floor of the mouth is the most common location aho amacandwa saliva ibiri kenshi, so naho zikunze kugaragara. Hari n'izijya munsi y'ururimi nazo zirahari cyane na hano mu Rwanda. So oral leukoplakia and erythroplakia are precursor regions. So oral leukoplakia, by leuko you understand there is something white, and then erythro there is something red. So we will see these regions afterwards, but these are regions ziza cyane cyane ku rurimi cyangwa n'ahandi muri oral cavity, usanga zimwe zireruruka izindi ziratukura. So they have a differential diagnosis, as we shall see, like oral candidiasis. And ubu ntihakiri abarwayi banduye sida bagira izi ndwara za candidiasis n'ibindi kubera ko bahita babaha imiti. Ariko mbere twiga tukirangiza kwiga aha, imiti yahabwaga umuntu ufite CD4 counts ziri hasi cyane 200. Yajyaga kuzigeraho rero yaragize these opportunistic diseases. So we had many cases of oral candidiasis and so on. But nowadays I think they are very few. So like oral candidiasis and leukoplakia, they look almost the same because they have whitish patches in the oral cavity. But the main difference will be that leukoplakia, iyo ushyizeho nk'aka base lang akantu kabasha mu giti cyangwa kare kose dukunda gukoresha tuzamura nk'ururimi uturebe munsi yarwo cyangwa urumanura ngo urebe mu ntanga, iyo ugakoresheje ushaka nko guhataho ibyo bintu, when it is candidiasis bivaho, when it is leukoplakia it doesn't. So that is the main difference, as we shall see. So leukoplakia, as I said, it is red. So no, there should be no confusion between it and the leukoplakia. Okay, so leukoplakia, as I said, cannot be scraped away. So, and often it represents squamous dysplasia, meaning that the cells have started to have abnormalities, although there is no invasive cancer. But we understand dysplasia in cell adaptations, you saw adaptations. You can have atrophy, can have hypertrophy, hyperplasia, metaplasia, and dysplasia. So dysplasia is a precancer lesion. When measures are not taken, it will lead to cancer. So, as I said, leukoplakia is distinct from rhodocandidiasis and hairy leukoplakia. So there is a table I have made there we will read. Leukoplakia is red and it represents vascularized leukoplakia. So it means there is a leukoplakia, but with much vascularization underneath. So, and this highly suggestive squamous cell dysplasia also. So it can mean that leukoplakia is worse than leukoplakia itself in causing cancer. They are basically almost the same. The difference is that erythroplakia is very much vascularized. So the pathogenesis of the oral cavity carcinoma, so here there is a normal mucosa, then hyperplasia or hyperkeratosis, especially under the tongue. Biravugwa ko kubera ko saliva ariho nyinshi biri naho haza ikibazo. So nubwo umuntu ashaka kwibaza ngo cancer mu kanwa is ahantu wenda haza ibiryo bishyushye, ahantu hahora hari traumatized, but it is not the case. Zikunda kuza hasi. So bisobanura ntabwo byoroshye kumenya impamvu yabyo. So there will be then dysplasia. Usually dysplasia, you will see that it is hypertrophied. Usange kureri yatangiye guhinduka wenda hariho ibintu by'umweru cyane. Yaba ari erythroplakia, then hakazamo aba reddish. So severe dysplasia or carcinoma in situ. On histology here we can see easily then there is overt cancer. Here the basement membrane is intact. Here where it is more blue, here we have many cancer cells. And you see that in addition to that, there is always an underlying molecular problem. So we have mutations here, such as mutations in chromosome 9, short arm region 2-1, where there is a protein called P16. So P16, P16, we use it in the pathology labs as a surrogate marker for human papillomavirus. So kwa kenshi ntabwo tupima human papillomavirus muri histopathology, dushaka kuyipima dukoresheje molecular ways, ariko iyo dushaka kumenya ko umuntu ashaka kuba afite HPV infection within cells, not in atari kwa kundi bafata fluid and so on. But you have a tissue, we want to know if in this cell there is HPV infection, then we do immunohistochemistry using P16. And there is one pathologist now, she works in Butaro. She was our student, so she did a study on the prevalence of HPV infections among the cancers of oropharynx and the larynx. And I think we saw 18% of all these cancers, they are related to HPV. So then we have mutation in chromosome 17, where there is a gene P53 that you know very well, the guardian of the genome. And this, if it is there, then it leads to have a severe dysplasia. Then if we have additional mutations here listed here in the cyclin and so on, there is a squamous cell carcinoma develop. So, yeah, and this shows that it usually takes a time to get into squamous cell carcinoma. Ntabwo ari ibintu biza ngo mu kwezi kumwe biba byageze hariya, unless immunity umuntu yagiye hasi. So as I said, we have to distinguish leukoplakia here, which are whitish, kandi ukaba ushatse kuzikuraho ntabwo byemera, ahubwo icyo gihe byasaba ko uruhu rwe rukagahita ava amaraso. And there is oral candidiasis. So nabyo ni umweru. There are some minor differences, but the main one is that when you scratch here, this can be removed very easily. And as I said, this is usually seen in immunocompromised people, HIV positive usually. So then hairy leukoplakia, it is leukoplakia also seen in immunocompromised individuals, but this one is caused by Epstein-Barr virus instead of HPV, which is the main cause, ni the leukoplakia. So bayita hair leukoplakia kubera ko ukuntu isa ikunda kugaragara iri rough nk'imisatsi. So that's why it's just called the hair. You will see some pictures aho ubona ari nk'imisatsi neza yamaze kururima. So that's the reason, and it is on the borders of the tongue. So that's all for the oral cavity. And as I said, of course, we will come back on this in the head method pathology. And I will not repeat this, of course, we will see other things that we have not covered now. So as soon as no question, then we can proceed with the salivary glands, also which we will cover. Yes.
What do you mean by surrogate marker?
Okay, surrogate, iyo bavuze ngo umuntu ni surrogate mother, ni urugero ushaka kuvuga iki? Ni umuntu, surrogate mother w'umuntu ni umuntu wamwitire ko ari mama we. So surrogate marker ni marker of a tumor, but which is indirect. So P16 itself, when it is a gene, ni gene umuntu asanga ntahuriye na HPV. Ariko iyo umuntu agize infection by HPV, iyo gene nayo ubwayo igira ikibazo, igira mutation. So bivuga ko iyo umuntu agize HPV infection which causes cancer, in these cancers, if the cancer was triggered by HPV, you will see a mutation in P16. So that's why if you want to know that a cancer cell was infected by HPV, you can see its P16 marker or gene. So I'm going to marker. So I think in tumor pathology, there is what we call tumor markers. Aho umuntu ushaka kumenya ko afite prostate upima PSA, prostate specific antigen, mu maraso ye cyangwa muri urine. Iyo usanze ari nyinshi uravuga ati umuntu ashaka kuba kuko afite prostate cancer. That is a direct marker because PSA is produced by prostate itself. Ariko ayita surrogate, donc niyo umutsindirano. Okay, niyo jambo ry'ikinyarwanda. Uyu utsindiriye umuntu umubyeyi, uwo mubyeyi aba ari surrogate. Iyi rero ni insindirano kuri HPV kubera ko ni gene idaterwa na HPV, ariko mutation yayo iterwa na HPV. So that's why it represents, it stands in the place of. That is what a surrogate means. Is it that understandable?
Yeah, clear.
Okay, thank you. So otherwise it is just a legal name. So ubushize turi, I think some years ago, 1 or 2 years, no, 1.5 years ago, we were twari mu nama ya forensic medicine. Then hari umuntu uvugira umuvugizi wa RIB, so he presented the cases. Ntabwo n'iryo jambo surrogate abaroyaze bararikoresha cyane, he's a lawyer. So yavugaga ku challenges hari mu mategeko, avuga ati duhaga urugero rw'abantu bashaka kugira abana ariko batababyaye, ahubwo bababyariwe cyangwa batwitiwe n'abandi. So there was a case aho umugore yashatse kugira umwana, none hashaka umuntu umutwitira akamwishyura amafaranga, ariko mbere kumutwitira aravuga ngo ashaka umuntu umusamira umwana. Ni ukuvuga bafashe ovule ye bayihuza na sperm cell artificially. So bamaze kuzihuza zigira zygote, then iyo zygote iyo fecondation ntabwo yabereye muri lab, ahubwo yabereye mu muntu. So umuntu wamusamiye arangije aravuga ati ariko ntabwo nshaka kuri ari untwitira, ni muyivanemo muyishyire mu ntwitira none. So you understand there are two. So aramutwita ariko yagomba kubishyura ni business. so akabishyura yaba n'ibihugu bya Buraya n'Amerika habaho abantu bakora izo business gutwitira abana nk'abo atari uko ariwe batewe inda ahubwo bazihuje ovire des cells then bakazimuhurizamo agatwita umwana yavuga akamutanga so aho ngaho uwayitwise rero uwo nguwo ushaka kumwita surrogate mother nada kubera ko yaramutwite ariko ntabwo ari we wamusana so icyo gihe yabivuga ko ikibazo cyajemo nuko uwatwise yahawe amafaranga agiye kubyara amaze kubyara akunda umwana ategeye umwana wanjye ntabwo mubwo hano imanza ziratangira ategeye umwana mu mateko n'uwanjye kubera ko regari kubera ko namukwishyuye ngo umuntwitire ndaravuga ati nanjye mu amategeko avuga ko nyina w'umwana ni uwamutwise wakaza n'undi wa gatatu bati nyina w'umwana ahubwo n'uwatanze ovire niwe ugomba kwita nyuma so umwe yari genetic mother undi yari biological mother wamutwise undi akaba surrogate mother wa undi ushaka kumwitira so the issue there was that amategeko y'u Rwanda hari umwe muri yo niwe amategeko yemera amategeko y'u Rwanda kugeza icyo gihe ntabwo nzi niba barabihinduye yemeraga mama w'umwana ni uwamubyariye kwa muganga uwagize delivery so icyo gihe rero avuga ati kugikemuza icyo kibazo amategeko asanzwe byarananiranye so I was just explaining the surrogate umutsindirane. So for the salivary glands, we have a major salivary glands and the minor salivary glands. So the major ones, we have a parotid, we have a submandibular, and we have a sublingual under the tongue. And these are the major ones. So we have a minor ones, many of them. In the oral cavity, so here it is written hundreds, it's written somewhere. Yes, hundreds of microscopic glands. So you cannot see them with eyes. But sometimes they develop tumors. So they are all over in the oral cavity, and even no hejuru ahagana muri palate ziba zirimo muri pharynx araho zisanga so salivary gland they secrete saliva. And you know in histology that the difference between these histologically they are different. Nuko bayikoreye biopsy bakayikuzana muri histology you should recognize this is a parotid or this is submandibular. The difference, if you remember well, is that the parotid gland is serous, so it secretes just a watery fluid, while the sublingual gland is mucus. It secretes things which is thick, virenduka with mucus. Submandibular, it is both. It is mixed serous and the mucus. So ahangaha nk'abanyeshuri biga ko yazabyibuke ikiri serous n'ikiri mucus nuko ikiri hafi ya oral cavity buri gihe kiba kiri mucus ikiri kure cyane ya oral cavity nicyo kiba kiri serous. So that's how we go just to remember anytime if you are asked. A salivary gland far from the oral cavity is serous, close to oral cavity is mucus. And the middle one is mixed. So we start with infections. So malformation and those are and because it's also with the pairs, left and the right. So so the infection we start with mumps. Mumps ni bita amashamba. Iterwa na virusi n'ubundi it is a viral infection ikunze gufata parotid gland cyane so uzasanga umwana ari bibazo kuna gufata yabyimbye itama rimwe nureba mu kanwa ugira ngo wenda afite mangine cyangwa ikindi cyangwa ari nodes enlarged ones sange nta birimo azaba afite umuriro as anyone who is infected by the virus. So azaba afite umuriro abyimba itama. So that's all. So the problem now with it, the problem ni hamwe bya systemic lupus erythematosus navugaga nuko iyi virus uburyo yataka umubiri, uburyo umubiri urwana, bituma hari n'izindi organs ziba affected kandi iyo virusi itagiyemo. Izo organ ni pancreas ndetse na testes. So this is very serious because hari abana bagiye bazirwara b'abahungu akazaba sterile kubera ko yayirwaye ntavurirwa igihe, virusi zikangiza testis. So there's a seminiferous tubules zikaba completely destroyed. So no spermatogonia, no sperm cells. So otherwise also it can damage the pancreas, it can cause meningitis and so on. So that's why it is very serious, especially when you see that it affects a bone. So for females, of course, it can destroy their pancreas, but usually it can regenerate. It cannot destroy the whole pancreas. Ariko ikibazo cya testis ni uko n'umuntu afite a certain number of normal spermatogonia and so on, ntabwo ziba zihagije, because you know, for someone to be fertile agomba, when he ejaculates, he must have at least, I think, about 8 millions of cells muri milliliter and so on. So iyo zigabanutsemo gakeya ntabwo ashobora kubyara, kuko nyinshi zipfira muri female genital system, ku buryo zishobora kugera igihe fluid igeze muri fallopian tube ahabera fecondation, akenshi ziba zarangiye. Iyo atafite nibura miliyoni 80 zigeramo zashize zose, akaba sterile. So bivugiye ko kuba pancreas yakwangizwa igice gito bitava ko itakomeza gukora, ariko kuri testis it is different. A number of normal cells matters much in testis. So sialadenitis, so itis, I think you remember itis, yes, it means inflammation. Sial, it refers to salivary, and then aden it refers to glands. So salivary gland inflammation. So it is also frequent, ariko cyane cyane iterwa n'iki, hari abantu bagira mu tube gusa tukazamo kuvuga calcium deposits, and then zigakora just small stones, what we call sialolithiasis. So I think you should be familiar with this word. Lithiasis means a stone. Igihe ari muri salivary gland, it will be called sialolithiasis. When it is in let's say gallbladder, it will be cholelithiasis, because chole refers to gallbladder and so on. So these stones, they just come there by accumulation of the calcium salts, and then iyo ibaye gutyo ifunga amacandwe. Iyo ifunze amacandwe ntave saliva ntizeyo, biruzura bikabyimba, and so on, bikamurya, bigatera inflammation. Akenshi it is a diagnosis you can just know through the history of the patient. Kakubwira ati giye biranje, ariko binijya cyane cyane iyo mbonye ibiryo cyangwa se ndi kurya. Ko iyo umuntu abonye ibiryo apeti kaza, salivary glands zitangiye gukora saliva nyinshi. Niba zikoze rero ikabura aho inyura, birushaho kumuza. That is the explanation. Icyo gihe uzahita umenya neza ko hari obstruction of salivary gland ducts somewhere. Then you examine to confirm. So that is sialadenitis. It can be chronic or acute. So here you see other signs: pain, of course, because of inflammation; swelling, because there is a stagnation of the saliva inside there; redness of the skin is a sign of inflammation, rubber; less saliva coming into oral cavity because it was obstructed here, and bad taste from the past, kubera wenda inflammation which is there ishobora kuba suppurative, hakazamo amashya, so mugatuma mu kanwa ke hano mugashobora. This can help you to diagnose sialadenitis. Otherwise ashobora kuza ukavuga ngo afite ikibyimba kandi atari cyo, ari just inflammation. That's why you have to be just consistent or having an oriented examination, not just examine. You should examine keeping in mind a possible diagnosis, not just to document things. So pleomorphic adenoma. So this is a most common benign tumors of the salivary glands. So akenshi cyose ntabwo hashira icyumweru tutabonye nk'abarwayi batatu at least muri pathology CHK baje gukora final aspiration for us to confirm if it is really pleomorphic adenoma or if it is a cancer, kugira ngo nibusanga ari cancer cyangwa atariyo, now the surgeon will know if they have to do surgery or not and so on. And you can see it here. So it is usually unilateral, affecting one side. Kiba kiri fixed, kiri deal ku buryo akenshi kijukeka ko ari cancer. So it is painless, it is usually mobile, circumscribed at the angle of the jaw. So munsi y'ugutwi ahagana imbere gato niho gikunda kuba. So ikibazo cyaho nuko ikunda gukora recurrence. So in the literature they say iyo ibazwe uyibaze neza, iyo uyibaze ariko ntuyibaga neza akayakanwa gato gasigaramo iragaruka, ariko nubwo yabagwa neza igashiramo, there is a risk of 25% to come back again. Another problem is that it can be transformed into a cancer, a carcinoma. Icyo gihe tuyita carcinoma X pleomorphic adenoma. So carcinoma X pleomorphic adenoma, meaning a cancer arising from a pleomorphic adenoma. So another tumor is called the Warthin tumor. So this is an eponym because it was discovered by someone, or described for the first time by someone called Warthin. So it's a benign tumor. Ikiranga rero ikitandukanya n'izindi ni cyatuma ishyiraho ni photomicrograph. So salivary gland, they have epithelial cells because they secrete saliva. That's why here we have epithelial cells. In Warthin tumor, there is an additional amount of lymphocytes. These cells, blue ones, they are lymphocytes. So it combines both lymphocytes and epithelial cells. These lymphocytes, they are just reactive, they are not a tumor per se. So they say it is the second most common tumor of the salivary gland, mostly after pleomorphic adenoma. So usually also arises from the parotid. So clinically, you cannot distinguish pleomorphic adenoma from Warthin tumor. It is histology or cytology which will distinguish them. So mucoepidermoid carcinoma. So this word epidermoid just refers to squamous. So these are cancers in which you have both features of squamous cell carcinoma and of adenocarcinoma, let's say. So cells producing mucus and cells which produce a keratin, if I can say so. So personally, I have seen that this is a carcinoma we can see in children. I saw children with this tumor. Ariko ubundi ntabwo abana dukunda kubonamo carcinomas, tubonamo za sarcomas, not carcinoma. But this one, I saw a child of 4 years having it. So it can be seen in oral cavity, in salivary glands, and so on. But usually it is seen in the salivary gland, and it is the most common malignant tumors of the salivary glands. Usually parotid, and ikibazo cya parotid nuko iri ahantu hanyura za fascial nerves and so on, ku buryo iyo hajemo cancer kenshi cyangwa se nubwo yaba ari benign tumor ukayibaga nabi noneho bitera risk yo kugira fascial palsy. So that's all for the salivary glands. Questions are welcome before we proceed with the esophagus.
Teacher, for salivary glands, the risk factors remain to be the alcohol and the tobacco.
Which you mean the tumors or?
Yeah, those cancers affecting the salivary glands. The risk
Okay,
factors remain the same.
We shall come back on this in the head and neck pathology. But in some, it depends on the type of cancer, because there are many cancers. Adenoid cystic carcinoma, acyclic cell carcinoma. There are many we have not talked about here, so we shall come back on this. But for some of them, chronic inflammation, chronic steatohepatitis, there is one of the risk factors. Otherwise, for others, no known risk factors. They just come.
Okay.
Okay, so we continue with the esophagus. Again, we start with the congenital anomalies, abnormalities or anomalies. And these are very serious issues. Kubera ko nibyo muzamubona mu bana, umwana azabona umwana avutse afite esophagus imeze nka gutya. So you recognize the trachea, usanga esophagus ye ntabwo ihuye hano. So birumvikana umwana ari mu nda, ibyo ntacyo abimubwiye, n'undi ntaba ashinzwe kurya, ntabwo aba arya, ntabwo aba ahumeka, ibyo ntacyo abimutwaye. So ikibazo kiboneka iyo avutse. Icyakora akiri mu nda, when you are a good doctor, you will recognize it. How? Kubera ko umwana we mu nda nubwo atarya cyangwa anywe, ariko ariya amazi yogamo barayanywa. So uko ayogamo akayanywa bituma amazi agabanuka, I mean the amniotic fluid. So ikizaranga rero umwana ushaka kuba afite ikibazo cya malformation in gastrointestinal tract nuko atazaba anywa ariya amazi. Natayanywa bizagaragazwa n'iki? Umumama agira amazi menshi, too much amniotic fluid. This is called hydramnios. Too much amniotic fluids. On the opposite side, igihe umudamu azaba afite too low amniotic fluid, umwana atwite azaba afite ikibazo mu mpyiko cyangwa muri urinary system. Why? Kubera ko ariya amazi yiyongera kuko umwana ayanyaramo ajyamo hariya. So uvuga arayanyara akanayanywa ni so. So iyo atayanyara avuga ko adakora urine aba make cyane. Iyo atayanywa ngo ayagabanye bituma arayamazi aba menshi cyane. So oligoamnios ni yabaye make. Oligoamnios would be most likely caused by urinary tract problems in the fetus, while polyamnios or hydramnios will be caused by problems, malformations in the gastrointestinal tract. So iryo ni ibanga ryo kugira ngo uzamenye gutandukanya ibyo bintu. So nujya muri stage ukabona umuntu ufite hydramnios akwaza urateye aho byatewe n'icyo gatangira rero kuvuga ibintu. So we have many kinds here. You see, first of all, on the list we have the type. We have a stenosis. Stenosis nyango hano ntayihari, ni ukuvuga hari ahantu ngera esophageal ikaba nto muri kariba, that is stenosis. So icyo dufite hano ni atresia. Atresia ni ukuvuga hari igice kimwe cha organ runaka kidahari, icyo bita atresia. It can be duodenal-atresia, it can be esophagus atresia, and so on. And fistula. Fistula ni ukuvuga nkaha hari communication between two different organs, whole organs. So n'umudamu aba afite fistule kubera iki? When hariho communication between the lumen of the, let's say, uterus and the urinary bladder. Bituma enda inkari zishobora kunyuraho zishaka icyo gihe. Rimwe na rimwe hakabona fistula between the uterus and the rectum. Kurya umwanda munini nawo ushobora kunyuraho ushaka. So fistula murabizi. So there's a communication between two hollow organs, or communication between one hollow organ and the skin. Ugasanga opening yagiye ahita itagombaga kuba. So that is also fistula. So fistula, communication between two hollow organs or one hollow organ and the surface of the body. And atresia, absence of a part or the whole of an organ. Stenosis, there is narrowing of the lumen. So these are the definitions. So umwana azavuka, ikizatangira kwerekana ko afite ibibazo nk'ibi nuko uretse bimwe bya hydramnios n'ibiki gusa bishobora kubaho ngaho akavuka cyangwa byatewe n'indi mpamvu. Hydramnios ntabwo iterwa n'ibyo navuze gusa, ishobora guterwa n'ibindi, ariko that should be kept in mind. Ashobora kuvuka rero, amaze kuvuka ikizakubwira nuko acyonka bwa mbere azahita agira ikibazo. Kubera iki? Azamira amashereka aho kunyura hano agaruke, cyangwa se niba ari muri iyi scenario hano upper right here, azayamira kubera ko esophagus itajyanye n'igifu, ahite ajya muri trachea, then abura uko ahumeka. Ukanya birumvikana ntabwo azaba. So ni icyo kiba, nicyo kizaba. So you should be able to explain this. Muzi ko muri iki gihe hari ibibazo byinshi bya niba ntabwo ari ugukanguka, ahubwo ngira ngo mu Rwanda n'abaturage hari ubwo bagira ikibazo kivuze, aho ikibazo kiba guhamagara polisi. Umwana agize ikibazo guhamagara polisi, kandi rimwe nawe ugasanga ni ibibazo nk'ibi. Nese bino umuganga wabo wabiteye, umwana yavutse ari muzima ngo none arapfuye, bagahita bafunga umuntu. Nese niba yari afite atresia, baba bagira ngo umuntu amureme. So ariko niba utabizi nawe uri umuganga, ntube wanasobanura ngo wenda afite atresia, bazakujyana nyine bagufunga, bakurengane, ariko nawe wirenganije kubera ubuswa. So that's why we should use the science to defend people, but also to defend ourselves. Kwako ntabwo ngiye nk'umuganga nshinzwe kuvuga ngo umwana wavukanye atresia ngo mukize, wamukize utese. Niba bitaramenyekana imbere ahandi mu bihugu byateye imbere, ni ukuvuga ababizi imbere bati twarabibonye umwana afite atresia, then ni uko azavuka na cesarienne, akavuka ahita ajya kubaho ahari. Ariko hano niba umuntu avukiye kuri health center cyangwa kuri district hospital, even teaching hospital, ntabwo mwamenye ko afite atresia, kubera wenda nta bushobozi mu bikoresho ari byo kugira ngo bimenye. Then nyuma y'iminota ingahe aravutse, ararize, ameze neza, bamushyize ku yerahisa, then ukajya gufungwa. So that is a big issue. So ngira ngo rimwe na rimwe hari n'igihe ubona ko biba ngombwa ko abantu bafata ibyemezo, navuga abanyamategeko bagomba gusobanukirwa n'ibi, cyangwa se abashyiraho amategeko nk'abadepite, bakanga ko n'icyo kintu gihari. Ntabwo ni nayo mpamvu nubwo byatembeye tavuga ngo abantu bose bavutse 100% babaho. Ni byiza ko imibare igabanuka y'abapfa, ariko ntabwo bishobora kuba 0%. Kubera iki? Kuko hari abavukana ibibazo nk'ibi bidashobora gukemuka uko byagenda kose. So but I think there is a possibility also to know, because when I was doing turi muri doctor ya kane Butare, muri shita kunibuka ko hari muganga, unfortunately he died nyuma nyangwa ya stroke yarapfa. Nibuka ko turi muri doctor ya kane hari umudamu waje bati uriya mudamu yari afite hydramnios imwe navugaga, so akora ecography. I was assisting him, aravuga ati cyewe ndi gukora ecography kandi nta bakozi b'umumama, ahubwo yarebye n'umwana, anareba esophagus yakiri mu nda, ati uriya mwana afite atresia. Arabivuga, mudamu yari ari aho ngaho, then mu nama ya staff ziba mu gitondo muri buri department, arabivuga ati uriya mwana rero afite, uriya mubyeyi umwana twita afite atresia. Bivuga nta kintu dushobora gukora mu Rwanda, ko ntabwo mu Rwanda babaga esophagus no kubana nakora. So aho kugira ngo bikomeze gutya, reka tufate icyemezo. Bafata icyemezo gusobanura uko ibintu bimeze, ko bagiye gukora kudeclaration, no kuva kumuhibise umwana akavuka, kandi akabazi neza ko aravuka atari we. So ndetse yarafite n'indi bibazo mu mazuru, malformation. Exactly avutse uko umuganga bivuze kuri ecography nuko byari bimeze, nta kintu na gito yibeshye. So bivuga ko hari ibyo dushobora gukora, ariko ahari byati nuko SHB yari ifite ecography ikomeye cyane, ntabwo iri ahantu hose ku buryo wayibona. Ikindi umuganga yari yarize n'ibintu bya, yakoze a certain course or certificate in ultrasound mu Bubiligi, so ntabwo ari uwari wese wabikora. So icyo nshaka kuvuga rero ni uko ibi bibazo birahari, kandi ni bimwe mu bishobora gutuma abantu bafungwa bazira ubusa, kubera ko n'ababyeyi baba bashaka gusa kugera kubigereka ku bandi. And I remember when I was working as assistant, hari umudamu wari cyane cyane abita abasirimu, yayigaga masters nijoro hanyuma atwite, nyuma aza kumva umwana ntabwo abuja mu nta muvomo, so abigira ibyoroshye arabyihorera yiberaho akiga, so rimwe na atangira kumva ameze nabi ajya kwa muganga. Hashize nk'ibyumweru kirenga yumvise ko umwana atakibusha. Ageze kwa muganga baramusuzuma, baramubwira ati ariko umwana we ntabwo agihumeka. So umudamu usirimu uziranywe n'abantu abantu bumva bakomeye, hanyuma arabahamagara ati umuganga yiciye umwana. Baraza abayobozi benshi barahaza, hanyuma umwana we muganga uyu umubyeyi w'inshuti abihorera. So umudamu bamuhibise kugira ngo umwana avuke. Umwana avutse basanga umwana yagize ibyo bita maceration, ni ukuvuga kubera yapfuye kera uruhu rwe rwarashwanyaguritse. So ba bantu bose hari aho harimo n'abazi iby'ubuvuzi bahita bakorwa n'isoni, tabona ko muganga bamwutse nabi bamurenganya, umwana yari yarapfuye kera. Ubundi umuganga icyo yabwiye umudamu avuga ngo madamu ntabwo nigiye kwica abantu, ubundi nawe ahita yigendera. So iba ko muri society turimo hari abantu bari arrogant, ikibazo cyose kibaye bumva kibaye bagomba kubona uwo bakigereka. Niba ari kwa muganga nyine umuganga akabishyira agafunga ni so ni byiza rero ko at least tumenya iyi situation, izi ndwara nk'izi zishobora guhitana ubuzima bw'umuntu kandi tudafite icyo twazikuraho. Ko muri ibihugu byacu muri East Africa cyangwa East Central Southern Zone Africa ntaho nzi babaga esophagus. N'abafite cancer of esophagus they just treat using either radiotherapy or drugs, no surgery. Kubera ahantu esophagus it is very difficult to do surgery on this. So I think also comparing to what we are seeing is the same here. Tracheoesophageal fistula. So usually when there is atresia, such as here in one or in this one, upper right or lower left, or even here, when there is a malformation in the esophagus, usually there is a fistula of esophagus to the trachea. So bituma noneho byongera ibyago ko umwana ahita apfa ako kanya akimara kugira akantu na gato yashyira mu kanwa. So they have been classified type A, type 2. So you see that there are differences. We will just read them and they differ. So these are congenital defects resulting in a connection between the esophagus and the trachea. Most common variant consists of proximal esophageal atresia with the distal esophagus arising from the trachea. So they say the proximal is missing. It is the distal which is there and which is connected to the trachea. Maybe like in DCC. So the consequence ahangaha birumvikana hano kuri C namira ibintu ko bitazagira aho bihurane na esophagus, ntabwo azamira ngo bigende kuzagaruka, ariko nta nubwo azahumeka nabi keretse bigarutse mu kanwa bikinjira muri trachea. Ariko ko ikindi gishobora kumaho n'iki nuko fluid from the stomach igihe igarutse inyuma nta handi ijya muri bronchi, then bikaba byajya mu bihaha nabwo agapfa. Ariko birumvikana ko uyu ashobora kumara akanya atarapfa ugereranyije n'abantu. So there is esophageal web. This is a radiograph. So ni radiograph aho baba babwiye umuntu kumera ibintu bita barium. So barium it is a chemical element, no? Ariko iri twahita kwiri opaque. So, yes.
No, I have question type C. Ubwo bivuze yuko uno murwayi kuri previous slide bivuze ko kuri uwo murwayi wa type C we adashobora kurya, biba ari ibyo ntabwo bigera mu gifu.
So urabona byageramo gute? Keretse nyine uvuze ngo nabimira binyuze muri trachea. kandi na reflexes zacu ntabwo zitwemera normale kumira ikintu ngo kijye muri toilette kijyamo ari ukwibeshya donc ari nka acid. So bivuga ko ararya bikamanuka bikajya muri esophagus, irafunze rero ntabwo birenga. Urumva ashaka kurya rimwe tukaguma hariya ariko ntabwo azonka utundi ngo tubibone aho tujya, n'utwo twa mbere dushobora kugaruka. So that's the meaning. Ariko kubera ko bitajya mu nzira ya respiratory system ashobora ntabwo yahita apfa ako kanya nk'uko uyu wo muri B byagenda, ko muri B byanze kunze bihita bijya muri trachea bikajya mu bihaha, ari B ari na D nuko bijya mu bihaha ako kanya. So ni ibintu byumvikana.
Okay, thanks.
Welcome. So navuga ko uyu muntu rero ni ibintu bisanzwe iyo bakeka ko ari ahantu hifunze muri esophagus, muri duodenum, so bafite izo products of contrast niko zitwa muri radiology, babishyira mu mazi ukabinywa nka fluid bisanzwe, bafotora kubera ko biri radio opaque bitemerera rays gutambuka muri byo, bihita bigaragara nk'umweru gutyo nk'uko ari umweru. So ahangaha ikigaragara ni ikintu uko umuntu yabinyoye, hari aho bitafashe neza hano, ariko icyo bashaka kumenya ni ahantu hifunze. Urabona ko hano hagaragara ko hari akantu kifunze, ni nka stenosis. Ariko stenosis ubona kenshi iterwa nuko habayeho increase in the thickness of the wall. Aha rero si icyo kibazo gihari, ahubwo ni nk'akantu k'akamambarane kaje hano, niyo mpamvu kitwa web, kazamo kameze nka kuriya imeze kagasa n'agafungaho gake hano muri esophagus. So gatuma ibyo umuntu ari yanyoye bitagenda byose cyangwa ngo bimanuke neza. So is a protrusion of esophageal mucosa, most often in the upper esophagus, present with dysphagia for poorly chewed food. When ibiri fluid cyane biratambuka, ariko ibiri solid birumvikana, poorly chewed food ntabwo bizatambuka. So these people, they have an increased risk of esophageal squamous cell carcinoma because uko amira habaho irritation ahangaha, cyangwa uko yamize ibiryo yagenda bikatinda bikora irritation, risk of inflammation and so on. So there is what you call Plummer-Vinson syndrome, characterized by severe iron deficiency, anemia, esophageal web, and beefy red tongue due to atrophic urositis. So birumvikana ni this is anomaly avukana ahantu henshi uretse muri esophagus. Hano urabona ko afite n'ikibazo cha tongue and akagera na iron deficiency anemia. So abo bantu babiri Plummer na Vinson who discovered that the disease have been named after their names. So another thing is zinc diverticulum. So ahubwo yango noneho esophagus yifunge, ahubwo ikora an additional pocket nkuko muyibona hano. So an additional pocket hano bituma umuntu amize ibiryo bimwe biramanuka muri esophagus bigiye mu gifu, ibindi byigire mo hari. So mu kujya rero bigatindamo itkane yango ikintu mugomba kumva neza nuko igihe cyose habaho stagnation of fluid somewhere, it has a risk to cause infection. Ko bigiriye accumulation of bacteria igashoboka and then infection. So that's why accumulating these things here, they will cause problems. Ibiribwa bikaboreramo, that's why they have halitosis, which is a bad breath. So yahumeka ukumva umwuka uranuka, nuka uyangajya brosa ariko ntibigire icyo bitanga, and so on. So this is Zenker's diverticulum. So Mallory-Weiss syndrome, this is a longitudinal restoration of the mucosa at the gastroesophageal junction. Muzuko hari sphincter ikomeye cyane hariya, ariko hashobora kuzamo ibibazo cyane igihe umuntu yagize vomiting. No kuvuga ibintu byo mu gifu byazamutse bijya hejuru, mu kubyiganira hariya bishobora gutezamo regions, hazamo ulcers. Another cause is the alcoholism. Another cause is bulimia. So bulimia is a psychological problem. Ngo nanani tuzayibona twarabivuze kuzayibwanga, ariko I didn't put it in this presentation. So bulimia na anorexia nervosa ni indwara zikunda kugaragara mu bantu bashaka kunanuka. ariko anorexia nervosa ni ukuvuga anorexia ni ukuvuga kubura appetite, nervosa ni ibintu byatewe na psychology y'umuntu, so akishyiramo ku buryo we adashobora kuryoherwa kugira ngo atarya ubundi agira ibiro bike. So ni abagore cyangwa abakobwa n'abakunda kubigira. So bulimia byo it is the opposite, naho umuntu arya ibiryo byinshi birenze urugero. Hari ababikora kubera uburwayi psychological mental disorders, ariko hari noneho ababikora adafite beat yo kurya nyirizina, ahubwo bati ngenzanya ndya byinshi noneho byose mbiruke ubundi mbona uko nanuka. So ibyo nabyo hari abadamu babikora cyangwa abakobwa. So that's bulimia. So it can cause that. These people, they will present with hematemesis. I have said in the morning that hematemesis is vomiting bloody vomits, and it will be painful because of these ulcers. Ubundi busanzwe wenda umuntu aruka amaraso wenda ava mu gifu kubera impamvu izitari ulcers, ntabwo aribwa niba byatewe n'ikindi kitari ulcers. So they have a risk of Bauer syndrome, which is the rupture of esophagus leading to air in the mediastinum. So to have an ulcer is one thing, but when the ulcer becomes very deep until it perforates the esophagus wall and then have a rupture, iyo bimaze kugira ngo nibwo yitwa Bauer syndrome. So here there is an explanation of this. So the most common causes are alcohol abuse, bulimia nervosa, coughing, hiatohernia. We'll come back on this. Hiatohernia ni ukuvuga igifu kirazamuka kikavaho kiba kikizamukira hejuru muri mediastinum gikurikiye aho esophagus inyura, niyo bita hiatohernia. Akaba na food poisoning, ni ukuvuga umuntu yamize acide biroroshye ko nigera muri esophagus cyane cyane agana kuri sphincter izahatera ibise, ko izabyiganira kunyuramo ngo igere mu gifu, kubyigana itere ibibazo muri hariya hantu. So others are descriptions, you will just read them. So here also to compare Mallory-Weiss syndrome and Bauer syndrome. So yirango ahanga murabona ko habayeho rupture of the esophagus wall, mu gihe hano gusa ni ulcers zirimo imbere but there is no perforation. Ikindi nuko uyu wa Mallory-Weiss syndrome najya aruka kuko muri kona azajya aruka amaraso, murabona ko n'icyayi muteye afite icupa ry'inzoga, mu gihe uyu nguyu nta vomiting kubera ko amaraso n'ubundi niba anahari azajya agwa muri mediastinum, ntabwo azirirwa akora vomiting. So endoscopy will help to diagnose this. Kimwe na ya zenka diverticulum, kimwe na ya esophageal wave, byose endoscopy ngira ngo murabizi, niba mutanayibona ni tube bohereza muri oral organs. So hano not muri esophagogastroduodenoscopy, aho yohereza muri esophagus ikamanuka muri stomach na duodenum. So ibiriho ahantu urebera nko kwa microscope ukagenda ureba uko imanuka, uko yohereza, ukareba niba hari lesion, any tumor, any ulcer, any abnormality ubonamo hano. Wayibona then you can take pictures, and usually nowadays they connect them to a screen ku buryo uburi kuyohereza yego n'amaboko yawe ariko urebera kuri screen wenda utareba muri objectives za microscope. So niyo isabona ibintu byose. So esophageal varices yango twazibonye kare, ntabwo ari ibintu dutindaho, ariko sano ziterwa n'iki muri esophagus. So the main reason ni abantu bagira liver cirrhosis. So with liver cirrhosis there will be entrapment of some of the veins or arteries of the portal circulation. So ibyo rero bizatuma habaho iki, niba hari amaraso yavaga mu gifu anyura muri izi vessels zinyura ku mwijima, then bigakomeza muri vena they go through the inferior vena cava, then bikazagera ku mutima. Aya maraso yahanyuraga kubera cirrhosis, you see this liver how it is nodular, amaraso ntabwo azabona uko atambukamo neza. so hanyitazamo icyo bita collateral circulation. Amaraso yo kunyura hariya ahita akomeza akiza agashakira inzira mu gifu, kubera ko hano ubundi hasanzwe utuveso dutoya dusa n'uduhura, ariko utu tuveso ntabwo dushinzwe kunyuramo ibintu byagomba kunyura muri porto area, ahubwo tunyuramo gusa amaraso bisanzwe makeya. Iyo abuze inzira rero asubirayo akaba ariho yinyurira. Mu kuhanyura za vessels zirabyimba, so uko kubyimba kwazo nibyo bituma habaho varices. Collateral circulation, ikindi ahandi baho abantu bafite cirrhosis bayibona n'abana, habaho na so vitelline sac, ira sac vitelline ibirimo nka nutrients zigenda zitunga umwana ari mu nda, habamo vessels zinyura muri umbilicus. So iyo umuntu atangiye kugira placenta, umwana uri mu nda, then ya sac vitelline ite agaciro kubera ko noneho amaraso nutrients ziva kuri mama we zinyuze muri corridors, so zivomwa na placenta. Icyo sac vitelline ntabwo bifite agaciro, niyo mpamvu vessels zavagaho zijya ku mwijima zitangira kuba degenerating, ariko ntizivaho burundu. Hari izo berekana ziba ziri aho ngaho nta maraso anyuramo ntacyo. Iyo habaye ikibazo rero cya liver cirrhosis, izo vessels zirongera zigafunguka amaraso akanyuramo. Nibwo uzasanga amaraso yagomba kunyura aha ngaha rimwe rimwe aza akazamukira kuri umbilicus, ukabona kuri abdominal cavity ko vessel zabaye nini cyane, kubera ko ya maraso yagomba kunyura hano portal area, amwe yanyuze muri izi veins in the esophagus and stomach, andi maraso anyura kuri umbilicus kugira ngo azabone uburyo azasubira ku mutima. So all these are called collateral circulation. So collateral circulation also, it can happen only in the brain. Bamwibuka anatomy neza, hari ahantu cerebral arteries y'iburyo n'ibumoso, hari utubranche twazo tujya duhurira ahantu, ku buryo rimwe na rimwe iyo imwe igize ikibazo, ibumoso igize ikibazo, iburyo ishobora kohereza amaraso ku ruhande rwayo, ariko akagera najya ibumoso handi hagize ikibazo nubwo ataba hari. That is also to be called the collateral circulation. So haro nibyo biba izi vessels zikaba dilated. So the big issue with esophageal varices nuko zikunda kuba ruptured. So when they are ruptured, umuntu ava amaraso cyane, birumvikana muri esophagus avamo ahita ajya mu gifu akaba menshi, atinze gupfa ushobora kuzabibona nyuma yatangiye kugira icyo bita melena. Melena ni ukuvuga ntabwo ari stools in the with blood, ahubwo stools harimo processed blood. So nuko ntabwo amaraso aba ari fresh aza muri stools, ni amaraso aba processed kwa yanyuze mu gifu anyura mu mara imusoro. Ntabwo ari kimwe n'amaraso yavukiye muri yatangiye kuza muri stools muri rectum. So ariko icyo nashaka kuvuga ni uko aba bagize rupture of esophageal varices, it is one of the causes of sudden death. Uburyo mu kanya gato cyane atangiye kugira rupture of these vessels ahita. So it is known among the causes of sudden death. So I think this collateral situation is what I was explaining. So it is asymptomatic normally, but when there is a rupture, then the death can happen. Otherwise, ni ibintu bashobora kubona kuri endoscopy gusa, igihe bakora endoscopy bakahita bazibona, wenda ari ikindi bishakira gatari zibari bagendera, kuko nta n'ikimenyetso cyagiye gihari ko yabazifite. Keretse hano musafite cirrhosis, ukaba ubizi nazo ukazishaka kubera iyo mpamvu. So achalasia is a disorder that esophageal motility with inability to relax the lower esophageal sphincter. Ibiterwa n'iki? Nuko ganglion cells, nazivuzeho kare, ganglion cells, so ngirango ni abazi igifaransa, ganglio ntaho ihuriye n'ibi. Ganglio ni lymph nodes mu Cyongereza. naho ganglion cells ni nka nuwayo ya neurons, aho muzi ko neuron iba ifite axon ndende cyane ku buryo axon ishobora kuba neuron ishobora kuba ifite nucleus yayo mu bwonko, ariko axon yayo ikagenda ikagera kure mu kuboko no mu kuguru and so on. But for some of the, for example, parasympathetic and or sympathetic nervous system zikunze kugira their nuclei not in the brain, zikunda kuba ziri muri periphery, muri intestines, muri stomach, muri esophagus. So their cell bodies are not in the brain but in the periphery. And why they are usually, they are in a group. They are like small military camps. Ziba ziri ahantu kure zishinzwe gukora akazi. Nuwayo zazo ziri aho ngaho, so ni nka base militaire. So when they are damaged, then there are consequences. So indwara ya akarasia ijya gusa niyo bita harsh plaque disease, turagarukaho nyuma, ifata muri intestines cyane cyane. So normally these ganglia, they are a part of ganglion cells or ganglia. They are a part of the parasympathetic nervous system. Nuko iyo zihari zituma muscles ishobora kuba relax. Iyo zidahari muscle ihora iri muri contraction ntifunguka. Iyo zidahari. So ikibabaho ni iki rero, abantu aho zangiritse haba constriction, noneho bigatuma lumen yifunga ahanga. So the lower esophagus sphincter doesn't relax. It doesn't relax because it has no ganglion cells. Consequence baho ni iki rero, nuko anga hifunga ahatabaye relaxation, harifunga aha hakurikiyeho hejuru akaba very dilated. Ariko kuba dilated nuko yakwende ibyo urya biragenda bikahatinda bigishakira uburyo bizinjira hari. Ni nabyo biba kuri rectum. Rectum naho iyo umuntu afite zira ganglion cells harifunga aha hejuru yaho stools uko zimanuka zikirunda hakabyimba akaba dilated cyane. So impamvu ndi kubyensista ni iki, nuko hari abaganga, some doctors bakora surgery yabona hari habaye dilate akagira ngo niho harwaye, nagiye mbibona akagira ngo niho harwaye, agafata specimen akagareza ngo muturebere niba uyu muntu afite hash plank cyangwa karazi. So okay, karazi hano iba of course karazi ya muri esophagus babaga rectum cyangwa colon. So akohereza igice cyabaye dilated, rero ugasanga ganglion cells zirimo. Wangwa ati je ganglion cells zirimo, akavuga ngo no ntabwo bishoboka, jewe umuntu nzi ko afite hash plank disease, it was very much dilated. Wamwaze teze wafashe he, amurumva nyine nafashe hari dilated cyane, none abanyari ikibazo. So kamenya ko n'ubuswa bwabiteye. Ahari dilated si ikibazo kiba kiri kuri distal to that area. So don't make the same mistake. So when you see dilation here, don't think the problem is here. The problem is where there is constriction. But there is a difference between akarasia and the harsh plank disease. So akarasia yo ni acquired, iterwa n'ibintu byaje bikica zira ganglion cells. Mu gihe kuri harsh plank disease ngo tubibona iyo ganglion cells ziba zidahari, ni ko umwana aba yavutse, niko aba yaremye. So hash plank disease hari nyinshi cyane nta cyumweru cyane tutabonye nibura eshatu. So you understand that ye muzakora stage bakubaza where do you think here we can take samples. Okay, inama ubundi bagirwa aba surgeons bagirwa niyo gufata hano hantu habaye hafatanye, agafata n'ahakurikiye hari dilated, when agafata no hepfo. Ibyo nukubera iki, nukubera ubwo ndi gutanga urugero rwa colon nubwo atari turi kwiga hano, nukubera ko mu gihe agiye gukora sutures agomba kuba sure ko noneho ahantu agiye gukora anastomosis hari enough ganglion cells kugira ngo cya kibazo kitazagaruka. So yo mpamvu akenshi afata biopsies ahantu henshi, rimwe na rimwe baba baneretse no gufunga inda y'umwana kugira ngo abanze bategereze tubabwire niba koko bafashe ganglion cells aho aho bashaka gukatira niba ganglion cells zihagije iyo tubabwiye ngo nta zihari barongera bakajya gukatira ahandi aho noneho barishyura ko zirimo ko nta kibazo kizagaruka. So gastroesophageal reflux disease, you understand there is the gastric fluid comes into the esophagus, and sometimes hari n'abazana acid ikagera mu kanwa kandi ibirura cyane itwika nka acid kuko n'undi na acid. So and its consequences you can understand. Niba ari acid zamutse kuri mucosa itaramenyereye acid, mwiga metaplasia ibyo mwagomye kuba mwarabibonye, nibwo bigeraho amasere yo muri esophagus, because they are squamous cells, they are not created to deal with acid. So iyo zibona rero hari hakomeza kubaho icyo kibazo, reka tubivuge mu mvugo y'abantu zisa naho zigina amabati kugira ngo dukomeze kubaho, reka natwe twihindure nka serire zo mu gifu cyangwa zo mu mara kuko arizo zimenyereye kwakira acid ntizigire icyo ziba. So niho hazabaho icyo bita intestinal metaplasia, ugasanga iki gice cya esophagus cyo hasi, the lining epithelium, it doesn't look the epithelium of the esophagus or the stomach, ahubwo isa n'iya intestine. So we call it intestinal metaplasia or Barrett's esophagus. So it is written here. Barrett's esophagus. It means intestinal metaplasia in the esophagus. Iyo yibonetse ubundi biba bisa naho bigiye kurangira umuntu agiye kugira kanseri vuba, keretse hafashwe measures zikomeye cyane zo kumuvura. So there are clinical signs nk'umuntu acid zamutse wumva ko mu gituza inyuma hari gushya, mimic cardiac chest pain with heartburn, asthma adult onset, umuntu utangira kugira asthma kuza atarigeze agaragaza ibimenyetso bya relish imbere. This is another sign, and cough. Damage to enamel of teeth, kubera iki iyi acide yiyeze mu kanwa, bumva acide yihuye na nibyo twakwita strong minerals nka calcium, it reacts with them automatically. So calcium ahantu hambere ihita ibona nyinshi no kuri teeth and so that can be explained. So that is gastroesophageal reflux disease. Akenshi nyine igira umuntu ufite ikibazo cy'igifu, birukana wenda kuruka biratandukanye, kuruka kenshi haza ibiryo nubwo bivanze na acide, ariko iyo reflux isa n'igihe umuntu nta bintu afite mu nda, atari ukubera uburwayi bumwe bwo kuruka, ahubwo gusa acide ikizamuka ayakumva amazamutse bitajyanye no kuruka. So
sorry, lecturer.
Yes.
Lecturer. Yeah, what caused this problem?
These factors are written here. Alcohol, tobacco, obesity, fat-rich diet, caffeine, hypertolerance, and hari n'abavuga kurya ntuza shokora, nabyo bajya babivuga, it is one of the risk factors. So ikibazo kiba cyabaye ni iriya sphincter iba yabaye rorashe. Otherwise igifu ni ibisanzwe kirikanyura, iyo kikanyuye iyi sphincter igomba gufunga ibintu byose ntagire ikizamuka. So when this sphincter doesn't work properly, then acid izazamuka very easily. Ubundi ifunguka iyo ibintu bimanuka cyangwa se umuntu ari kuruka, kubera ko umuntu haba harimo imbaraga nyinshi mu gifu zibizamuka, ariko iyi ni acid izamuka nta n'imbaraga nk'izo kuruka zinshi, ahubwo ikazamuka because the sphincter is open. So ibintu byose bishobora gutuma sphincter ifunguka n'ibyo byaka wenda shokora ngira ngo irimo caffeine niyo mpamvu. So I think I answered your question. So hiatal hernia, nayivuzeho kare ni igifu gishaka kuzamuka ngo gisange esophagus aho iri. So this is normal condition where the stomach is in the esophagus and the diaphragm is here. And here you see that there is a section of the stomach which went above the diaphragm. So this is the sliding hiatal hernia. Here it is lowering. Murabona ko igifu ntabwo cyazamutse nk'igisunika esophagus, ahubwo cyazamutse nk'indi pocket, just besides the esophagus. So here they are both combined. Mixed striding and rolling. So, and there is a type 4, which is not shown here. Herniation occurs when the stomach as well as another organ is amukan. So, on these 3 types, it is on. So, it means the stomach goes there and it goes with the intestine or spleen. So, that will be type 4. But the most common one is this striding hernia. It is seen in 95% of the hernias. So type 2 and 3 and 4, they're known as paraesophageal hernias. Paraesophageal because they slide just beside the esophagus. While type 1, it pushes the esophagus. Ntabwo iza iri ku ruhande rwa esophagus. So the factors here, they are aging, increased intra-abdominal pressure, obesity, and so on. These are the risk factors to have hiatal hernias. So the balance esophagus. Yes. Yeah, I had that. So that one can mute him or herself. So the Barrett esophagus, as I said, there is a metaplasia of the raw esophagus mucosa from stratified squamous epithelium. This on the left, ugasanga hajemo epithelium. So it is columnar epithelium. N'igifu gifite columnar epithelium na lower part of esophagus nka centimeter ebyiri hejuru ya diaphragm. Esophagus nayo ifite columnar epithelium. Ariko iri hano ntisanzwe. Harimo goblet cells. Goblet cells ziba muri intestine, ntabwo zijya ziba muri stomach cyangwa lower esophagus. So iyo zije muri niho twemeza ko umuntu agize intestinal metaplasia. So tujya tugira n'abafite intestinal metaplasia mu gifu, nabyo bigaragaza ko ashobora kugira kanseri. But the higher risk of developing cancer is when this happens in the esophagus itself. So, and as I said, that it is seen in 10% of people with gastroesophageal reflux disease. Yes, it is okay. So may progress to dysplasia and adenocarcinoma. So this is important. There is no way you can say Barrett esophagus will cause squamous cell carcinoma. No, it will cause adenocarcinoma because it starts with intestinal metaplasia, meaning there are glands coming. Then from glands, we don't have squamous cell carcinoma. From gland, we can have adenocarcinoma. So the last section on the esophagus is carcinoma. So as I was mentioning just on the previous slide, you can have adenocarcinoma on the lower part of the esophagus, or in case there is a Barrett esophagus. So another type is squamous cell carcinoma. If the Moravi's histology of the esophagus, the upper part and the middle part, they are in the by squamous cell. Stratified squamous cell epithelium. The lower part are about 2 centimeters, designed by a columnar epithelium like that of the stomach. So the most common type of esophageal carcinoma in the West is the adenocarcinoma. In the West, when we say West, they are developed countries of Europe and the United States and Canada. And of course, the Japan also. America and Canada, so is mentioned among the Western countries. So it arises from the pre-existing, this adenocarcinoma, pre-existing Barrett esophagus, usually involving the lower 1/3 of esophagus. So for the squamous cell carcinoma, it is on the upper and the middle thirds of the esophagus. And its major risks are alcohol, tobacco, very hot tea, and ukunda kugaragara mu cyane cyane abahinde bakunda kuba bafite utuntu tw'icyayi bahora banywa dushyushye cyane, so bakunda kugira ikibazo. Other risks are achalasia. You remember achalasia, it is like sub-occlusion of the esophagus because the ganglion cells has been killed. Other risk factors are the esophageal web that you have seen and the esophageal injury and so on. So I think that's all. Ariko ikindi tugomba kuvuga ngano nuko squamous cell carcinoma it was seen related to HPV infection. So there is a study which was done. We have done. The main investigator was the Dr. Bunga, who was recently a minister of state. So twabonye ko muno mu Rwanda bahari bafite esophageal carcinoma ziterwa na HPV. So HPV doesn't only concern the genital organs or oral cavity, but also the upper esophagus. But also there are other research projects which have shown that Epstein-Barr virus also is involved in the pathogenesis of some of esophageal cancers. But in our context, alcohol and tobacco smoking, they are the most common reasons. Buryo niyo umuntu ufite esophageal cancer, by'umubare usanga ari umuntu wanyoye itabi imyaka n'imyaka cyangwa itabi n'inzoga dusoma. So esophageal carcinoma presents late, and unfortunately kubera ahantu iri ikindi kibazo bagira poor prognosis kubera ko nko mu bihugu byacu ntushobora kumukora surgery, you rely on radiotherapy and chemotherapy. So the symptoms will be dysphagia, solid to liquid. So nukuvuga dysphagia, it means difficult in swallowing. So it starts with solids. Wenda yamira ibintu biribwa bikomeye bikanga kugenda. Ubwo biba byatangiye aho iyo bigeze aho no kumera amazi cyangwa fluids byanga, ubwo nyine byamukomeranye. So others are weight loss as any other patient of a cancer patient, pain and hematemesis. So when the cancer bleeds, of course, agira vomiting with blood. And squamous cell carcinoma may additionally present with hoarse voice, chane when the laryngeal nerve is involved. So akenshi umuntu afite wenda guhindura kwijwi, so hoarseness of the voice, akenshi ukeka ari ikibazo cya larynx, mugakora endoscopy igira muri laryngoscopy mukareba ugasanga wenda nta kibazo kirimo. Icyo gihe rero as a differential diagnosis you should feel niba umurwayi afite wenda loss of weight, pain and so on, akagira ijwi rye rigahinduka ukumva nta ikintu kiriniga atari guatre, wakora laryngoscopy bakavuga ngo ni normal, so you will think about esophageal cancer, then you request for for the internal medicine especially to do endoscopy. Kubera ko laryngoscopy zakorwa nabo muri ENT cyangwa ORL. So there are lymph nodes which are affected. You know, carcinomas when they metastasize, they go through lymphatics. Therefore, the lymph nodes are the first site to receive the metastasis. So the lymph nodes which can be affected, they are the upper third of the cervical lymph nodes, middle parts, and then the lower parts. These are called the celiac and the gastric nodes. So nukuvuga cancer yo muri lower third of esophagus is afata muri celiac and the gastric nodes. The cancer of the upper part of upper third of the esophagus, it will metastasize through cervical lymph nodes, zino umuntu aparuka hano kw'ijosi, and then the cancer of the middle third of the esophagus will metastasize through mediastinal or tracheobronchial nodes. So nahangaho agombye gushakira as a clinician yo bamaze ko endoscopy ariko afite cancer aha lymph node ntabwo niba kwa afite cancer muri lower third uzaya gushakira muri neck. So byaba ari nk'ubusazi, ugomba gushakira aho literature yerekana ko ziza bwangu, ntibuje ko zishobora na nyuma kuzajya kuri neck, ariko aho bizagera yaratinze cyane. Any question? So we can have a break. I think 8 minutes break because we have a long way to go. So I have been slow. So 8 minutes, then we proceed. So welcome. I hope you can see the screen, and we proceed with the diseases of the stomach. So for the stomach, we start with gastroschisis. So these are malformation, of course, as usual for the other organs. We start with malformation. So gastroschisis is a congenital malformation of anterior abdominal wall, leading to exposure of abdominal contents. So you can ask yourself, why do we present this with on the stomach, not on intestine and so on? So we can present it anywhere. Niba ni intestine zagiye hanze or stomach, and so rimwe na rimwe n'ijavuka n'umwijima uri hanze and so on. So we call it gastroschisis when it is congenital. Otherwise, this can happen. Niba bibayeho ari traumatic, wenda yagize accident bijya hanze cyangwa yarabazwe, hanyuma habaho dehiscence, then zikajya hanze, that will not be gastroschisis. Bizitwa ikindi evisceration cyangwa se evisceration. Evisceration igihe zagiye hanze nk'uku kwa gastroschisis, but which is not congenital. Naho eventration igihe ziri hanze ariko zikiri muri membrane runaka, donc utahita ubona ngo uriya ni intestine and so on, ahubwo zikaba wenda zikiri muri aponevrose and so on. So on the other side we have omphalocele. So omphalocele, there is a herniation for the bowel into the umbilical cord. So murabona ko hano ziri ahari, hanyuma umukondo ukaba munini cyane kuko zirimo ariko ntabwo zibona hanze z'ubwazo. So this is called omphalocele. So I think these are things that you can easily distinguish when it happens that there is a child with these abnormalities. So pyloric stenosis ni nka bimwe twabonaga hejuru kuri stenosis of the lower esophageal sphincter. So it happens. So when it happens, then it will cause the food not to proceed from the stomach to the duodenum. So that is the consequence. Birumvikana ibibazo byinshi, igifu kigakoresha imbaraga ngo cyohereze ibiryo aho kugira ngo bimanuke bikagaruka. So here this diagram is showing the pathomechanisms of and the consequences of these things. Ariko igikunda kugaragara nuko biba mu bana batoya few weeks after birth. Kubera iki? Uko wenda amera amashereka kirunda hano bigatinda, noneho hagatangira kubyimba, haza n'akantu ku buryo ukoze palpation urakumva, bakita mu gifaransa bitaga olive duodenale. So it is like a fruit, nk'uko pome iba imeze gatoya cyangwa se ipera, uragaparupuka kumva karimo kubera iyi sphincter iba yakomeje kubyimba. So it is olive like. So mu Gifaransa ita olive pylorique. So in English they kept this word olive. So now we go to the inflammation. We start with acute gastritis, and there is a chronic gastritis. So this is the acidic damage to the stomach mucosa. So ubundi uko igifu cyacu kiremye nuko habriho mechanisms zo to keep balance between the acid production and the mucosa of the stomach, which protects the stomach from being injured by the acid. So byombi birakenewe. Nta wabanga acid ubundi yaremewe ikiyo imaze iki. It is helpful. Iyi mucosa nayo it is helpful. Mucus, it is helpful because it defends or it protects the stomach itself from being injured by that acid. So I think this is physiology. So acid damage results in superficial inflammation, erosion. So it means a superficial layer of the mucosa being removed, and then ulcer if there is a loss of the whole of the thickness of the mucosa. So the risk factors are severe burn. Tuvuga umuntu yahiye ku ruhu bisanzwe n'umuriro, ibi ni ibintu bishyushye kubera stress n'uburibwe bwabyo hari ubwo bitera imbalance between in other things, so bigatuma habaho decreased blood supply to that area, and then because of that there is ischemia and necrosis nk'uko twari tubona no ku ruhu igihe hari vascular problems. Other risk factors, they are the use of non-steroidal anti-inflammatory drugs nka za aspirine, ibuprofene, diclofenac. Iriya ni imiti murabizi ko buriya bayihaye umuntu wundi mubwira ko iramurya mu gifu iraryana n'ubusanzwe. So ni ukuvuga ko umuntu ayirya rero buri munsi aba afite risk y'uko igifu cye kizaba inflamed. So iyi ni imiti ikunda gukoreshwa igabanya zira za prostaglandin A that we saw in inflammation, is a mediator of pain. So there is a heavy alcohol consumption, chemotherapy, increased intracranial pressure, Cushing syndrome. So why? Because the increased intracranial pressure will cause increased stimulation of the vagus nerve. Kandi murabizi ko this vagus nerve niyo ubundi ituma habaho gukora acide nyinshi cyangwa nkeya. Ni nayo mpamvu muzajya muziga na muri surgery n'ahandi ko iyo umuntu afite akora acide nyinshi irenze urugero, mucosa ni normal, mucus production is normal, but the acid is too much produced. Ikihe cyo bakora baragenda bagaca nerve, vagus nerve branch ijya ku gifu, uko vagus nerve ijyana henshi, so branch ijya ku gifu bakayica kugira ngo idakomeza gustimira igifu gukora acide nyinshi. So rimwe na rimwe nuka kera niga abantu babajije muri church baza ngo ubundi kubera iki bahuza psychological issues n'indwara z'igifu. So this is one of the reasons. Else nerves nubwo ishobora kuba stimulated na intracranial pressure, ariko ishobora no kuba stimulated na psychological issues. So bigatuma psychology itera vagus nerve gutuma igifu gikora acide nyinshi, then with acute gastritis and so on. So other causes are shock. Abantu bafite shock nk'abari muri intensive care unit ICU bashobora kugira this gastric, bajya barazigira. Niyo mpamvu uzasanga kenshi nubwo yaba atarwaye igifu bagenda bamuha imiti irinda igifu, nuko bazi ko stress or shock or the shock itself or any other severe stress can cause someone to develop the acute gastritis. Cyangwa se rimwe na rimwe ukabona umuntu wenda usanzwe urwara igifu ariko cyabaye controle wenda kubera imirire ye na discipline, ariko niba azi ko arajya mu bintu biri stress, tuvuga agiye mu kubazwa ibintu bishaka kumutera stress n'ibindi, icyo gihe agiye afata iyi miti kugira ngo yirinde ko acide yaza kumubana nyinshi. So that is for acute gastritis. So mainly caused by overproduction of the acid. For the chronic gastritis, of course, this is a chronic inflammation of the mucosa of the stomach. There are two types. It can be either autoimmune or caused by H. pylori, Helicobacter pylori. So if we start with the autoimmune one, it is due to autoimmune destruction of parietal cells, meaning that the stomach, the body itself produces antibodies which will destroy the parietal cells in the stomach. And of course, muzi ko mu gifu parietal cells ntabwo ziba kuri antrum, ziba kuri body and fundus. Niyo mpamvu ariho iyi chronic gastritis itewe na autoimmune disease, autoimmune stimulation, ntabwo izaba kuri antrum, mu gihe itewe na H. pylori akenshi ifata kuri antropyloric region. So I think that is one of the factors. So if we are asked, someone is having a severe chronic gastritis on the fundus, so do you think this is H. pylori related or is it autoimmune? So hope you will be able to answer that. So it is associated with antibodies against parietal cells or intrinsic factor. Mwara is muri physiology. ituma habaho absorption of vitamin B12 and so on. So the pathogenesis is mediated by T cells. So in immunology, you have seen the hypersensitivity reactions are type 1, 2, 3, and 4. So 4 is mediated by, is cell mediated. I think type 1 is the one which is the allergy. So clinical features, there will be atrophy of the mucosa. Sometimes with intestinal metaplasia. So this figure, I have not put it. This is a histology. So there is acroridria. So means there is a low, there is no production of the chlorhydric acid. So acid chlorhydric. And there's increased gastrin levels and antro G cell hyperplasia. So these G cells, they are the ones producing gastrin. So that's hyperplasia, you know, it is increasing the number of cells. So if these cells have increased in number, then they will also produce a more hormone. Megaloblastic anemia, that the one I was saying, which is related to intrinsic factor. So intrinsic factor is destroyed, therefore the nubwo waba ufata ibiribwa birimo vitamin ikenewe hariya ntabwo izagenda kubera ko intrinsic factor yayifashaga kuba absorbed at the intestinal level is not there. So these people, they have increased risk of gastric adenocarcinoma of intestinal type. So the second category of chronic gastritis, as I said, is caused by H. pylori. And this is due to H. pylori, of course, Helicobacter pylori. And it is the most common form of gastritis, actually. So nowadays at our hospital at Sashika, when we have any specimen of the stomach, be it a cancer or not, we intend also to see if there is the H. pylori infection. So H. pylori urases and the proteases, along with inflammation, weaken the mucosal defenses. The antrum, as I had said before, is the most common site. So H. pylori gastritis affects the antropyloric area, while the immune-mediated one affects the fundus and the body. It presents with epigastric pain, increased risk of ulceration, peptic ulcer disease, gastric adenocarcinoma, intestinal type, and multi-lymphoma. Multi is mucosa-associated lymphoid tissue. So murabizi ko muri intestines na stomach barimo lymphoid tissue, muri mucosa, hagati ya mucosa na submucosa. So there's a lymphoid tissue, then they can be stimulated to and be cancer cells causing lymphomas. So these lymphomas, they are not much frequent, but they exist even here in Rwanda. We see them. So the treatment involves tripotherapy. Tripotherapy nuko muzajya mubona muri district hospitals abarwayi muzaba bafite benshi b'igifu, abarwayi ba hypertension, aba diabetes ni benshi cyane. So treatment yayo bayita therapy ko ni imiti itatu, ni antibiotics zikomeye cyane. Ukombina harimo metronidazole cyangwa bita fragile, hakaba n'indi antibiotique iri penicillin, kuko nizo zishobora kubasha iriya H. pylori. Then bongeraho n'undi muti wo kurwanya overproduction of the acid. So hari iyo bongeraho irimo amoko menshi biterwa na indications. Hari omeprazole n'indi ijya kumera gutyo, niyo myiza ngira ngo kugeza ubu, ariko hari n'indi isanzwe za cimetidine, ranitidine nazo zishobora gutangwa. So it depends on a patient and many other factors. So negative urea breath test and the lack of stool antigen confirm eradication of H. pylori. So urea breath test ni ikizami gikorerwa muri clinique, ntabwo kiza muri labo, ni icyo bari kuvuga ahangaha. So iki ni kimwe baragikora, iyo basanze kiri positive nibwo bashobora gufata sample noneho ijya muri laboratory to confirm that this is really a virus. So ikibazo kiri ahangana ikihe rero, kuvuga ko yabaye eradicated mu muntu ntibivuga ko itazagaruka. And that is the most dangerous scenario we encounter nowadays. So umurwayi araza gusuzuma akasanga ntayikirimo, ariko nyuma y'amezi angahe akagaruka ugasanga zirimo. So ni bagiteri yandurira mu mirire cyane cyane abantu bavuga kurira hamwe, amaresitora, ibikoresho nyine icyo wakoresheje none ejo ndaragikoresheje, cyangwa se icyo amaze gukoresha bakyogeje n'amazi adatetse ako kanya, then ukafata ya bagiteri. So birandura cyane cyane ahantu bashaka kurira bakoresha ibikoresho babihinduranya hagati yabo. And this is a serious issue now. So ikibazo rero gihari ni nuko mu Rwanda dukoresha imiti ikomeye nk'iratirite kuva kera. Even when I was working in this city hospital, we are using strong drugs, ariko habaho recurrence. Maze gusobanura ibya recurrence. Ikindi kibazo gihari ni nuko zira kanseri zirahari nyinshi z'igifu. Ngira ngo ushize muri Chumazi nigeze kubivugaho, kanseri y'igifu ku bitaro ibyinshi bya mu Rwanda niyo tubona ari nyinshi, nubwo wenda muri administrative or politically wenda hashobora kuvuga izindi, ariko niyo twe tubona ko ari nyinshi. Gusa hari impamvu zibisobanura, nuko ibitaro nka CHUK cyangwa se ya CHUK ikorerwamo endoscopy nyinshi kurusha ahandi, bisobanura impamvu wenda tuhabona kanseri nyinshi z'igifu kurusha izindi. But when there was a cancer registry ya hagati ya 2002-2005 aho yari ihari yarakoraga, nubwo yaje guhagarara, ariko mu gihe yakoraga byagaragara ko mu gihugu cyose kanseri y'igifu ariyo nyinshi, kandi itewe n'iyi virus ni bacteria. So ikibazo kikaba ko izi ndwara zivurwa neza, iyi H. pylori ivurwa neza, ariko bikanga kanseri y'igifu ikazamuka kandi bwa kwitewe ni H. pylori. Ikibazo gihari ni iki? So this is an issue we have, and we have to do we start to do research on this. And as I said, there is a colleague who went for PhD in Japan just because of this, to see the reasons of that. So probably when he will be done with his studies, we will have now a way forward what to do. Do we have to change the drugs? Kwako H. pylori ziri mu amoko menshi. Imiti dufite ishobora kubifata ubwoko bumwe. Hari ubwoko bita western, n'ubufata eastern. Eastern ni uvuga ibihugu nk'Ubuyapani, western ni muri Europe. Ubwo nta nubwo tuzi ubwo buri hano mu Rwanda. So ibyo byose tuzabimenya, then turebe niba n'imiti abarwayi bahabwa ishobora kuba yahindurwa. And in general pathology, you know, the gastric cancer is the most common in Japan. Niyo mpamvu ubushakashatsi bwinshi bukorwa cyane ku ndwara z'igifu Ubuyapani buza imbere, kuko ni menace kuri bikomeye cyane. So peptic ulcer disease, so birumvikana mu gihe umuntu yagize inflammation, then mucosa ikaba eroded, that this is a ulcer. So nuvuga icyo yavuga ngo yagize igisebe, cyangwa abanyarwanda bavuga ngo igisebe, igifu cye cyarapfutse. N'ubu igifu cyacu ntabwo kigira ubwoya nk'ihene cyangwa inka. So ni icyo bavuga, igifu cyarapfutse cyajeho igisebe. So the solitary mucosa ulcer involving the proximal duodenum and the distal stomach, ubu nicyo cyitwa peptic ulcer. So ni ulcer ishobora ifata aho ngaho stomach, lower stomach, upper duodenum. Akenshi biri kuri duodenum. So duodenal ulcer is almost always due to H. pylori. Ikaba ishobora no guterwa na this is the Ellison syndrome. So iterwa na overproduction of is it gastrin? So there is an enzyme which is overproduced in this syndrome. So maybe I have seen that in pathophysiology. So it presents with epigastric pain that improves with meals. Birumvikana hari ibintu ushobora kudiagnosing ubajije umurwayi. Umugabo ese iyo uri kuribwa igifu, iyo ufashe ibiryo, iyo ufashe icyo kurya, uburibwe buragabanuka cyangwa buriyongera. So niba bugabanuka ni ukuba ko afite peptic ulcer, afite ulcer. niba bwiyongera uburibwe nuko agifite gastritis gusa. So this can help to know even without doing endoscopy. Ikibazo ni afite byombi, afite asaze hamwe ahandi akagera gastritis, aho niho haza ikibazo. Diagnostic endoscopic biopsy shows the ulcer with hypertrophy of Brunner's glands, because here we're dealing with duodenum. Usually it arises in the anterior duodenum. When present in posterior duodenum, rupture may lead to bleeding from the gastroduodenal artery or acute pancreatitis. So we know this is severe when it is on the posterior duodenum. So the gastric ulcer is usually due to H. pylori. Other causes include non-steroidal anti-inflammatory drugs, aspirin and so on, and the bile reflux. So tuonyeka kuri reflux itari iyo pylorus itari yo hejuru muri esophagus, ahubwo bile aho ngango ikomeza imanuke, kuko muzi ko imanukira muri duodenum igakomeza ijyana n'ibyo umuntu yariye. Iyo bibaye ikibazo ikagaruka muri duodenum hagana hejuru cyane cyane ikagera ku gifu, noneho biba ari ikibazo. So ngira ngo hanga twabonye ko peptic ulcer of the duodenum iterwa na kuri 95% ni H. pylori, naho ulcer yo mu gifu H. pylori ni 55%. So don't be confused with these numbers. 75% is for gastric cancer, 95% is for duodenal ulcer. So here the symptoms they worsen with meals in a difference to the duodenum. So duodenum yafashe ibiribwa afite duodenal ulcer arorohe. Iyo ulcer iri mu gifu yafashe ibiribwa arushaho kuribwa. Ulcer usually located rectal curvature of the antrum. And you should also be aware that na cancer y'igifu na hangaho ibi kuri rectal curvature of the antrum niho cancer. Kuryo niyo ubaga igifu uramutse umubaza utaza aho nta endoscopy yakoze nikubwira hari ikibazo, wikoze blindly, ubundi ugomba kufungura kuri rectal curvature kuko kenshi nta tumor ziba zihari. So uba wanga kuhita unyura muri tumor kugira ngo wanze uyirebe neza utanatuma ibleeding. So ugomba kunyura hari normal, then ukanga uyirebe neza urebe niba ushaka kuyikuramo and so on. So ulcers of the stomach and cancers of the stomach usually on the rectal curvature of the antrum. I hope this is understood. So rupture carries the risk of bleeding from the gastric artery, of course. So the differential diagnosis of ulcers include the carcinoma. Kuko hari carcinomas zitera ulcer, ni kibyimbe hejuru ahubwo kika ulcerating. So it happens. So that's why usually they take a biopsy, even if they say it is an ulcer, they cannot confirm this is a benign ulcer or it is a cancer. That's why they have to take biopsies. So gastric ulcer can be caused by gastric carcinoma. Okay, first of all, the duodenal ulcers are almost never malignant, the facts nuko duodenum ntabwo ikunda kugira cancer. I think in my career I have seen maybe only one cancer in the duodenum, but in the stomach there are very many. So benign ulcers are usually small, sharply demarcated and surrounded by radiating folds of the mucosa, while the malignant ulcers, meaning ulcer which is associated with cancer, they are large with irregular borders and they have hipped up margins. So margins zizamutse cyane kurya ulcer ubona yatebeyemo hasi. So the biopsy is required for the definitive diagnosis, of course. So this diagram is comparing acute gastritis, chronic gastritis, and the peptic ulcer. So you will just read it, so I don't have to go through it again. So gastric carcinoma. So icyambere hanga turareba gastric carcinoma, ariko cancer zifata igifu ni nyinshi, nyango harimo akadiagram kazerekana, harimo ani nyinshi. Hari izituruka kuri maso rare, tuzita gastrointestinal stromal tumors. hari za lymphomas twavuze, hari carcinoid tumors za niba kuri neuroendocrine cells, then hakaba na carcinoma iva muri mucosa itself. So there are like 4 classes of tumors of the stomach. So here we'll discuss gastric carcinoma because it is the most frequent one. Otherwise, there are the other types we will not see here. But when you go in deep, for example, those who will do surgery or who will do pathology will learn more about them. So this gastric carcinoma, the malignant proliferation of superficial epithelial cells causing adenocarcinoma, because these are epithelial cells and glandular ones. So hari umuntu wazikoreye classification yitwa Lauren, so asa nubwo imeze kuriya ni kuri imeze nubwo en principe ari igifaransa kwanditse nuko yakuri n'uwo muri Norway, muri Norvege. And this man, he has lived for a long time in Tanzania, in Kilimanjaro. There's a hospital there. Yahakoze igihe kinini. So niwe watanze classification of gastric cancer, adenocarcinomas ikoreshwa kugeza ubu ku isi yose. So it is remotely yavuze types ebyiri, intestinal type and diffuse type. So intestinal uba ubona ikora amaglands ajya kumera nkaho muri intestines, kandi akenshi iza habanje kuba intestinal metaplasia. Naho diffuse type ntabwo zikora glands, buri serire biri ukwayo, and this is more dangerous, more deadly. So intestinal type is the more common. It presents a large irregular ulcer with heaped up margins. Most commonly involves the restal curvature of the antrum, similar to the ulcer. I think this I mentioned it. The risk factors that are intestinal metaplasia, which is due to H. pylori and autoimmune gastritis, nitrosamine in smoked food. Yango tureba carcinogenesis in general, barabibonye nitrosamine ni zituruka kwa hantu henshi harimo ibiribwa pre-cooked foods which are in supermarkets, so they put things just as preservatives for them. So these preservatives, when they are metabolized by our system or by our normal flora, the bacteria in the body, normal bacteria, if you can say so, they produce a nitrosamine which are carcinogenic. And this is mostly in Japan, but in smoked food in Japan. So nitrosamine ishobora kuba ari yatewe na smoked foods byandi bashiririje cyangwa bokeje, and then hari niyo iza bashyira muri as a preservative of any foods, not only these smoked ones. Ikindi nuko cancer ikunda kugaragara ku bantu bafite amaraso y'ubwoko bwa A. So blood group A, they have a higher risk of developing this. So the connection is not well known, but it is just a fact they saw. Diffuse type is characterized by staining ring cells. So ni cells zisa nk'impeta, iriya mpeta cyane cyane abadamu bambara ifite akantu ko hejuru, niko zo cells ziba zikoze. That's why they are called like that. They infiltrate the gastric wall. So ikiba kuri abangaba rero ni iki, nuko iyo bakoze endoscopy ntabwo ubona ikintu, baba za cells zinjira muri wo imbere zigakomeza zigakurikira zikaba zanajya muri duodenum zigakomeza zidasohotse inyuma, haba kuri serosa cyangwa kuri mucosa. Ku buryo kuri endoscopy n'izindi exams ntacyo ubona umuntu gusa yarashize. Wenda wagira combination of exams ukabona ko there is an increased thickness of the wall, niho ushobora kubikeka. Gusa ikintu ukora endoscopy ni igifu wumva ko gikomeye cyane, niyo ukoze surgery wumva ari ikintu gikomeye nk'urukwi, nicyo kikuya ko ari ikibazo. Otherwise mucosa will be intact. So when the wall is thickened ikaba hard, nibyo bita kera babitaga rhinitis plastica. So ni ijambo ryakoreshwaga kera ko n'ubu rimwe na rimwe rakoreshwa. So this one, diffuse type, is not associated with H. pylori. It has no intestinal metaplasia, and it is not associated with nitrosamine as the intestinal type. So for this, it is not really easy to know the risk factors for it. We just see it in. So unfortunately, it has a poorer prognosis ujyanye na intestinal type. So irica vuba iyi ngiyi the diffuse type. Gusa niyo nkeya kurusha intestinal type, even in Rwanda. So gastric cancer then presents with weight loss. Ibimenyetso bishobora kugaragara umuntu ayifite weight loss, abdominal pain, anemia, and are satiety. Ni ukuvuga ahaga vuba, akarya utuntu dukeya kumva igifu kiruzuye. Rarely present with as acanthosis nigricans or lesser sign. So acanthosis nigricans ni ukuvuga uruhu rwe rurakagasha, so thickness yiyongera birebye kuri histology kandi rukaba umukara cyane, nigricans, it refers to that. So hari ababigira ariko ntabwo ari benshi. Iyo sinya niyo bita lesser sign. So as the other carcinomas, the gastric cancer will spread through lymph nodes. It spreads through lymph nodes. So ahangari ikintu mugomba kumenya, these lymph nodes gensire ibanza kuri lymph nodes zegeranye n'igifu, hariya kuri lesser curvature, hari celiac lymph nodes, aho ngaho nizo zifatwa bwa mbere. Ariko ikimenyetso kindi kijya kibyerekana, umuntu uzabona afite enlarged lymph node on supraclavicular area left side, iyo bita virtual node, ntabwo ari virtual triad navuze kare, imwe muri hypercoagulability muri thrombosis, ni is the virtual node. Iyo node iyo iri ibumoso hejuru ya clavicle bone, you be very careful. It is a sign that this is a cancer from the stomach or the duodenum if possible. Mu gihe kanseri iva mu mwijima ijya kuri supraclavicular node ariko y'iburyo. So that is known. That is known. So a left supraclavicular lymph nodes in a context of a cancer, ubona ko yara ibirabyo kunanuka ibiki, think of gastric cancer. Right supraclavicular node in a context of abdominal mass, think about liver cancer metastasizing there. So izo clue mbabwira zigira akamaro, nizo zishobora gutandukanya n'abandi bantu when you take care of that. Ku buryo iyo ubonye umurwayi uhita umenya icyo ushaka. Nubonye supraclavicular node ibumoso ugahita okay, I think I have to check the stomach. Mu gihe utabizi hazajya kujya kandebe ko ari tuberculosis, reka ndebe hano wasanga afite ikibazo mu bihaha cyangwa se mu mwijima, so azaba ari guta igihe. Wenda birashoboka ariko that is very rare. So as a healthcare professionals, usually you must know the most frequent things. Ntawe uzaguhora ko umuntu yagize kanseri tuvuge yavuye muri appendix ikametastaza muri left supraclavicular node, ukabiyoberwa ukaba warabimisinze, ntawe uzabiguhora. It is very rare. Ariko if you miss, someone comes with weight of loss, with history of abdominal pain, then he comes with a left supraclavicular node, then you miss among the differential diagnosis to say gastric cancer. You can be in trouble. Nuhuwa uzakira muri weekend wakira umurwayi ararembye cyangwa n'undi umusore wose, then you have to present it to the senior medical doctor, to you. Kamubwira ati your supervisor nta kintu y'uyu akenshi iyo wenda wamwakiye muri weekend, mu gitondo mu nama Monday nibwo mujya mugapresenta abo mwakiriye, then you give differential diagnosis, bakazasanga wibagiyemo the most frequent one wagombye kubuza. Aho niho havukira ibibazo. Aho niwavukira ibibazo usanga ushobora kujyana ibibazo n'abarimu bawe, ni nk'icyo kibitera n'ibyo bibitera, kandi baba ntabwo nabarenganya ko ni ibintu wagombye kubuza. Ariko niba ari ikintu kiri very rare and you miss it, nobody will condemn you. So distant metastasis, most common, they go to the liver. Other site they are peri-umbilical region. So if byavumbuwe n'umuntu witwa okay, babyise Sister Mary Joseph nodule. So yari umuryango ni umudamu cyangwa ni umubikira witwaga Mary Joseph. So muzi ko abazungu bakunda kugira amazina hano dufata nka first names gusanga neza afite gusa. So Joseph wenda n'umugabo we cyangwa ni se then witwa Mary. Niba ari umubikira nyago Joseph yari se ntabwo nibuka neza, ariko ikizwi nuko ni umudamu, ni umukobwa cyangwa umudamu wavumbuye uburwayi kandi ntabwo ari umuganga. She was just a nurse. So abaganga bakajya bakabaga umunasi wakitegereza kwa kundi baba basista gusa nyine watemerewe kubaga, nyuma aza kuvuga ati nyamara maze kubona ibintu, maze kubona ko abantu bafite utubyimba kuri umbilicus akenshi baba bafite kanseri zavuye mu nda, mu gifu, mu mara n'ahandi, ariko zikaza kuri umbilicus. Arabyandika then bihita bimwitirira. Mugenda bababagaho ibyo ntibari banabyitayeho, so byahise bimwitirirwa. So ntabwo rero bivuga ko Sister Mary Joseph nodule buri giva ku gifu, ahubwo any intra-abdominal mass can metastasize to the umbilicus. Ibyo biterwa na ya vitelline sac navugaga mbere aho yari iri na ya connection iyivaho ijya kuri most of internal organs including stomach, intestines and so on. So ikindi kihari nicyo ita Krukenberg tumor. It is when the cancer of the stomach metastasizes to both ovaries. This will be called Krukenberg tumor. So bimwe twita eponyms. Eponyms are amazina afata indwara zifite amazina y'abantu bazivuze bwa mbere. So Krukenberg ni wabonye bwa mbere, Sister Mary Joseph abona buriya virtual nodule, virtual yabonye biriya and so on. So I think the notes here that are important, this slide, there are many things which are very important for you, which will help you to be a good medical doctor or not. So the appearance of the gastric cancer, it can be polypoid. So polype yose, polype ntabwo ari diagnosis. Polype ni uburyo akamase kaza kameze nk'agacuma niko nabivuga, kakaba karimo imbere muri lumen of the organ, stomach or intestines or even on the skin. Kameze gutyo. It can be fungating. So ntabwo ari nk'agacuma gusa ahubwo kameze nka cauliflower. So gafite digitations, ubona ko ari very irregular. It can be ulcerated like here in C, or it can be infiltrative. Ya indi twavugaga ya diffuse carcinoma nuko bimeze nkuko nabivuga. It just infiltrates through the wall. You don't see anything on the mucosa or on the serosum. So these are the 4 appearances of the gastric tumors, but also any other tumors also they have this. So the main subtypes and their frequencies. So mko navuga so diagram nije wayikoze kubera frequency ngira ngo iyi carcinoma y'ubwayo irenga 90% of all gastric cancers. Then you have a gastrointestinal stromal tumor and the leiomyosarcoma, meaning a cancer rising from the smooth muscle of the stomach. So you see it's a percentage here. And then you have a lymphoma and the neuroendocrine tumors. Wenda tuzazigarukaho nyuma muri colon. So ni nkeya nga muri stomach. But they exist. I think this year I have only seen 2 neuroendocrine tumors of the stomach. Kandi ziba zisa na carcinoma zisanzwe. You have to go to be a thorough pathologist kugira ngo ubashe kubona ko ari neuroendocrine. So hari ibintu tureba muri chromatin, hari utabyitaho. So usually mbyitaho nka wambaza ngo ni gute abonye ko ariyo. So hari ibyo bita salt and pepper chromatin. Ni sinye ibimeze nkaho urusenda, birabisenda bini ruvanze n'umunyu, uko ubivanze mu kantu niko chromatin bisa. I mean DNA. Kugira ngo ubone ko ari neuroendocrine. Ariko wenda abantu benshi nakunda kubyitaho. Yabonye ko ari carcinoma, just avuga carcinoma. Ntiyite kwa niba ari neuroendocrine kandi zivurwa mu buryo butandukanye. Question so far? So no question, then we proceed with the small bowel to make sure we... Yes?
My question is, on the previous, you said that most of gastric cancer are found on the lesser curvature, but
Yes.
this slide it shows the on a gross appearance they are on a greater curvature.
Yeah, this is just a representation. It is not the true scenario. Kwari ukwerekana shapes zazo, ntabwo kwari ukwerekana aho ziba.
Okay.
Ni ukwerekana aho ziba shape zazo, si ukwerekana sides. So niyo mpamvu zose ubona ziri kuri greater curvature. Bien sûr, no kuri greater curvature zirahaba, ariko they are very rare. They are very rare. Personally, I have not seen any on the greater curvature. Icyakora kuri fundus na cardia hari izo nabonye nke.
Okay.
Ariko kuri greater curvature no. So, if we go to the intestines, we start with the developmental abnormalities, duodenal atresia. So this is a normal duodenum. Of course, these are the diagrams, they are not the true pictures. So we have here a web blocking the lumen. Nkaya web twabonye kuri esophagus, kaka membrane kazamo imbere. Then we have here there is almost no connection. There is just a small tissue, ariko nkuko na tissue ntabwo yanyuramo ibintu fluid or food. Ntabwo yanyuramo hanga muri type 2. Type 3 there is no connection. There is just a gap between them. So this is duodenal atresia. So atresia, as I said when we talked about the stomach, it is the absence of a part or the whole of an organ. So kuri stomach ntabwo twavuze malformations uretse birya byo gusohoka kwa intestines and stomach, ariko nazo zibaho. Hari umuntu usanga ufitemo pancreas igice cyaho kibereye mo hagati muri stomach. So I saw, I think, one case at East Africa. So there are some other malformations. So this is a congenital failure of the duodenum to canalize associated with Down syndrome. So trisomy event. So clinical features, this patient will have polyhydramnios, nabivuzeho kare, kubera iki kwako uriya mwana ntabwo abanywa aya mazi, kandi kuyanywa nibyo bituma agabanuka. I mean amniotic fluids iri ibe muri placenta, muri munda igihe umubyeyi atwite umwana. So distension of the stomach, because birumvikana ibyo anywa bihera hano mu gifu kako bizatambuka. Blind loop of duodenum and bilious vomiting. So ni umuntu uzaba aruka cyane, ariko bilious bishobora kuvuga iki? Bishobora kuvuga ko avuka hakazamo bile. Niba bile izamo ni ukuvuga ko atresia yabaye hasi ya ampoule dovatere hariya bile yinjirira muri duodenum, nicyo byabivuga. Otherwise atresia ibere hejuru nta bile ntawe yahurira n'igifungo agire vomiting. Okay. 1 second, I come. Okay, so can you proceed? So the second is the Merkel diverticulum. So ni akantu k'agapocket kaza kuri small bowel, bisa naho ni agapocket nk'akandi twabonye zenka diverticulum kuri esophagus. So ni akantu nk'agaposhe kiyongera ku ruhande. Consequence yako ni uko hitekeramo ibiryo, imyanda bitewe n'aho kari, with risk of infection, perforation, and so on. So it arises due to the failure of uterine duct to involute. Nukuba uterine sac ntabwo yagiye burundu, hari uduce twayo twasigaye. Involution, apoptosis yayo ntiyabayeho ngo irangire, so igumira aho ngaho attached to the wall, bowel wall. So iba iri hehe rero, ibiyiranga bavuza rule of 2s, ni ukuvuga mu biyirangazamo umubare kabiri cyane cyane. So nibyo basobanuye hanyuma muzabona mu bitabo byinshi kiba kigaruka rule of 2s for Mekeri diversity camp where you are asking about them. 2, icyambere harimo 2% of the population nibo bayigira. So then with that it becomes the most common gastrointestinal tract congenital anomaly. It is at 2 inches long. It is 2 inches long. So urumva ntabwo twazindura muri santimetero kabiri kahita gataka. Niyo mpamvu 2 inch igumaho. Long and located in the small bowel within 2 feet of the ileocecal valve. So uvuye kuri metero zingahe, uvuye kuri ileocecal valve ugaruka inyuma, ugaruka hejuru niho iri. It can present during the first 2 years of life with bleeding. These are the signs and symptoms. Volvulus intussusception or obstruction, and it can mimic appendicitis. Cyane cyane iri iburyo, it will mimic appendicitis. But in most cases will be asymptomatic. No bakwana bazaba ifite batanabimenya, waba uri kumbaga umuntu ukayibona atari cyo wari umuhaje ibindi ukakabona nako ukagakura, ukenda gukora cesarienne cyangwa ikindi kintu ukagakuramo. So aya magambo ya volvulus na intussusception turagarukaho nyuma. So volvulus ni ukwihotora kwamara, intussusception ni urura rwiyinjiramo bwa. So turi bubibone nyuma. So okay, ni nayikurikira volvulus is a twisting of the bowel. So ikirero nubwo tukiyerekanye hano muri small intestine, ntabwo, this is very rare in small intestine. Volvulus, it is frequent in the colon. Ntabwo rero turi bugarukaho kuri colon kubera ikibazo cy'umwana, ntabwo twabigarukaho. So ibyo mubifate. Volvulus is seen mu bantu bakuze imyaka hafi 40 around there, kandi igafata colon. Intussusception igaragara ku bantu bakiri bato kandi igafata small intestine. So this is a law. Exceptions they exist, ariko this is a law. Volvulus is for adults and affects colon. Intussusception is for young and it affects small bowel. So someone will open the microphones. Can you mute yourself? Okay, but I say this, there are exceptions. So in the last few weeks, I think 2 weeks ago, we had a case. So and it falls to be an exam for one of our postgraduate students, and he failed it. He failed it. So this is serious. So to know which is more frequent in a colon, which is frequent in a small bowel. So that it was a colon, but with intussusception. Then I asked him, so do you think volvulus should be seen frequently in the colon, intussusception in the colon? He said yes. So that was a problem because it should be known. And the umutego wari urimo nuko kuba yaraje ngo suka ari ikintu kiza, byanze ko ari ikintu kidasanzwe cyahabaye. So there was a tumor, and he could do not at least say probably there is a tumor which is causing this, and he was the one handling the case. At least we should have examined to see if there is a tumor. Akenshi haza iyo atari tumor iterwa n'inzoka nini nka za scaries zo zibitera, otherwise ntabwo ari ikintu cyakunze kuba. So the intussusception nkuko mubibona na ahangaha, ururura ruri hano, igice cyo proximal part rwaje rwiyinjiramo bwayo. Mu kwinjiramo gutya rero hahitabaho obstruction, kuko ntabwo ibiribwa cyangwa se imyanda ikomeza kunyura ahangaha, byose bihita bihagarara, abakagera cyo bita acute abdomen. So acute abdomen it can be caused by obstruction of intestines, and the obstruction of intestine they are either volvulus or intussusception. Another cause of acute abdomen, it can be perforation ya organ, yaba stoma, yaba intestines and so on. So hari ibintu bizagufasha icyo gihe indira byimba cyane muri izo scenario zose. Ntabwo rero uzamenya icyo ari cyo utamusuzumye neza, utanarebye byahaje ni umwana muto cyangwa ni mukuru, yagize trauma cyangwa ntayigize, hari isinya yerekana ko yafitemo nk'ikibyimba cyangwa inzoka and so on. So then you are confused, you do x-ray. Iyo ari urura cyangwa igifu cyatobotse, hari gaze ubona yazamutse iri munsi ya diaphragm, munsi y'ibihaha, munsi ya diaphragm uhita ubonamo ko harimo gaze. So icyo gihe umenya ko habayeho perforation. Iyo idahari, ikintu uba uzakeka ni ikirero cya intussusception or volvulus. So that's how you should go. So niba ari test yaka ukayaka uzi icyo ushaka kandi ufite impamvu iri sound, atari ukupfa gukora ibizami tuma umurwayi atakaza amafaranga nta mpamvu. So the small bowel infection, so you see that the bowel here is reddish, but there is an area which is black. So in gangrene, so because of infection. So the small bowel is highly susceptible to ischemic injury. So niba harimo thrombosis cyangwa embolism muri any of its arteries, it will cause the infection, which look like this. So ibi nabyo ni imwe mu mpamvu zitera acute abdomen. So acute abdomen ibaho kubera iki rero? Uko umubiri wacu uteye, iyo hari ikintu kidasanzwe kije gukora irritation mu nda, haba muri peritoneum, haba kuri stomach cyangwa kuri intestines, icyo umubiri wacu ukora ni uguhita uparariza ikintu cyose kiri mu nda. So ni nka mechanism de defense, uhita uparariza ikintu cyose bigatuma peristalsis, ziriya muvoma z'amara wumva buri gihe abagenda rimwe na rimwe agonga, bihita bihagarara. Iyo peristalsis ihagaze, ntabwo stools cyangwa se n'ibiryo bishobora kugenda, na gaze ubwayo ntihita. Niyo mpamvu sinye kwa muganga azayavuga ngo afite arrêt de matière et de gaz. So no stools, no gas. Ni ukukwera iki, amara ahita aba pararize, igifu kikaba pararize, ntibyongere gukora contraction n'imwe. So impamvu yabitewe nuko habayeho volvulus, yabitewe nuko habayeho intussusception cyangwa se hawe perforation, cyangwa hari gaze yamenetse, hari acide mu rugero yamenetse muri peritoneal cavity, cyangwa se hajemo infection muri peritoneal cavity, cyo bita peritonitis. Ibyo byose bituma izo organ zose ziba parariza ako kanya kugeza igihe ikibazo kizakemukira. So ibyo byose aho biza umurwayi waza ari acute abdomen, ibyimbye cyane, aribwa, rimwe na rimwe afite umuriro niba ari peritonitis and so on. So it will be up to you. Cyangwa se bamwe afite appendicitis iyo yatobotse, nabyo byara peritonitis. Nuko abarwayi baza bameze. So as a medical doctor you say ni after acute abdomen, that is one. So the next is to know what is the cause of this acute abdomen. Nibwo ukora izo investigation zose as we are seeing. So hari izindi ndwara ziterwa na intolerance ku biribwa na bimwe, nk'aho afite intolerance kuri lactose. Lactose muzi ko ni ibiri mu mata cyangwa ibintu bijyanye n'amata. So niba afite intolerance kuri yo, hari ibizamubaho. So this diagram explains most of things. So normally lactose will be catabolized by lactase, which is an enzyme, into glucose and galactose. So I think this is a basic chemistry that mubona mwikiga mu mbere muri kaminuza. So but there are some people who don't have this enzyme. Iyo badafite enzyme no kuba ko amata banyoye ntabwo aba catabolized, ahubwo kwa ko umuntu wenda aba yanyoye n'amazi n'amata, icyo bibyara niki, biramanuka bikava muri small intestine bikajya muri large intestine. Ahangaha niho bikagera bacterial fermentation, kuko muri large intestine nubwo dushyiramo niho tugera cyane cyane normal flora, bacteria ziberamo gusa ziraho zitagize icyo zitwara. Small intestine ntazihari. Iyo bigeze muri niho haba fermentation because of this bacteria, ugasanga umuntu afite gaze nyinshi, na za acide ukwazo, wapima muri stools ukabona gas, ukabona acids, then akaba ari umuntu ufite gas, ni ukuvuga amara ye ahora yuzuye. So nta nubwo bitinda nawe ubwe ahita yerekana ko adashaka kunywa amata, nubwo ari akana yanywa amata agahita agira ikibazo, ukabibona ku buryo nawe yamukora cyangwa nawe ubwe wayamuha agahita yanga. So ni intolerance ku bintu bijyanye n'amata. So this enzyme characters is more active in this small intestine area, not in the large one. Another intolerance niyo bita celiac disease. So aba abantu bagira intolerance on gluten. So gluten intolerance ni ikibazo wenda ino ntitubimenya, ni ukuvuga ko uyu muntu n'umuntu utarya ibintu byose birimo gluten, ni ukuvuga ibintu birimo imigati isanzwe ntabwo ashobora kuyirya kuri they are rich in gluten, ibigori, ingano n'ibindi nk'ibyo ntabwo ashobora kubirya kubera birimo gluten. Yabiriya agira ibibazo bikomeye, diarrhea and so on. So when I was in Sweden, we had there is an American lady, we were working together in a group, so yari afite icyo kibazo, ariko yaje kuntangaza nuko hari undi mukobwa waje muri group yacu uvuka muri Bosnia. So she was normal, but like 2 years later she developed also this. So nukuvuga ko ntabwo ari ikintu umuntu avukana, it can be acquired later umuntu ari mukuru. So there are issues here. There are absorbed. The gliadin is deaminated by tissue transglutaminase. So deaminated gliadin is present to antigen-presenting cells. This you have seen in inflammation. Antigen-presenting cells ni cells dufite mu mubiri iyo ari yose ishobora gufata ikintu cyateye umubiri ikajya kucyerekana kuri T lymphocyte kugira ngo zibashe kugisuzuma zimenye niba ari ikintu cy'umubiri cyangwa ari ikintu cyavuye hanze. Niba cyavuye hanze T cells zikice cyangwa zikoreshe izindi mechanisms. So there are clinical signs. Usually children with abdominal distension, diarrhea, failure to thrive, ni ukuvuga n'umwana we. So akivuka akomeza guhondobera nagira akabaraga and so on. So adults classically present with chronic diarrhea and bloating, dermatitis, petiformis, and so on because of deposition of IgA antibodies. So muri rusange ni indwara ikiza kubwira rero nuko nahagarika ikintu cyose cya gluten azahita aba mutaraga. And there was a case at South Africa like 1 month ago. Then they took a biopsy. Twarebaga features tukazibura inyinshi kuko hari international protocol yo kuyemeza. So turasanga features nyinshi ntazifite kubera iki ko bafashe biopsy bamaze igihe baramukuye kuri gluten. So intestine zari zarongeye kwiyuburura zimeze neza, mukoza zimeze neza, so ntitwabona ikibazo cye. So these are laboratory findings and so kuri histology, this is a diagram, is not a true picture. Ufashe the mucosa of the intestine, this is normal way, normal person, the villi would be long, while in celiac disease azatakaza izi virosity. The villi will be lost, it will be flat like this, very atrophied. Nicyo kibiranga kuri histology. So nibyo twashatse dusanga nta bigihari kubera ko bari bamukuye kuri gluten. So iyo bayifata mu gihe aragifata imigati n'ibindi twari kuba. So tropical sprue is like celiac disease, naho atakaza villi ariko bitewe na infection, ntabwo ari autoimmune, ntabwo ari ikintu kirwanya gluten kiba cyabiteye, ahubwo we ni infection zindi ziba zabiteye. Binagaragaza nuko wari umuntu wagize diarrhea mbere irimo infectious wenda atewe na bacteria kandi wamuha antibiotics akoroherwa, mu gihe wa celiac disease mu antibiotic ntacyo bihindura ku burwayi bwe mu gihe cyose udahagaritse gluten. So here there are explanations. Explanations here. So the damage is more seen in the jejunum and the ileum, and this is secondary vitamin B12 or folate deficiency may ensure kubera ko hano habera absorption of this folate and vitamin B12 zikavanwa mu byo umuntu yariye bikinjira mu maraso. So umuntu azaba birya ariko bye kugaragara mu maraso. So another disease, Whipple disease, it is caused by an infection we call the Trophilema Whipperi. So it comes from this word Whipple. So Whipple ni umuntu wayivumbuye mu bitabo mwazamubona n'amafoto ye wavumbuye iyi ndwara. So what happens in this? Umuntu afite iyi ndwara na afashe izi bacteria ziba phagocytized by the macrophages. None izi macrophages zazifashe nizo zitera ibibazo zikajya muri lymph nodes, zikajya muri ya mucosa associated lymphoid tissue in the intestines and so on, hakazamo ibibazo. So nuva ni indwara idafata amara gusa ifata ahantu henshi hatandukanye. Ariko hanga tuyivuze kubera ko inibasira amara igatera malabsorption and diarrhea. So the classic site of involvement is the small bowel lamina propria. The macrophages will compress the lacteals. The chylomicrons can't be transferred from enterocyte to lymphatics, and this results in fat malabsorption and steatorrhea. So steator, when there is this prefix steator, it refers to the fat. Or then it refers to the stools. So there is too much fat in the stools, steatorrhea. And it is explained here why. It is because these fats umuntu aba yariye ubundi zigomba kujyanwa kunyura muri enterocyte zikinjizwa muri lymphatic vessels. Ndumvikana fat ubundi ntabwo igomba kujya mu maraso direct, because fat ntabwo ari hydrosoluble kandi mu maraso ajya mu bintu biri hydrosoluble. So that's why it should be absorbed and then taken to the lymphatics. So aha rero ntiba bishobora kujya muri lymphatics, therefore ikomeza gutakara muri stools, ugasanga zirimo fat nyinshi kandi umuntu ukazabona ko afite ikibazo mu maraso cye cha fat yagiye hasi cyane. Kwa ko at the end these lymphatics the fat inside the lymphatics will be catabolized, bigahindukamo zira bita za so harimo za cholesterol, very low density lipoprotein and so on, izo zishobora kugenda mu maraso none. So we have also a beta lipoproteinemia. So a beta ni ukuvuga iyo hajyaho E irahakana, ni ukuvuga ko uyu muntu adafite beta lipoprotein ihagije, iyi A ihita ihakana ko atabifite. So these people, they have absence very low density lipoprotein and low density lipoprotein in their plasma. And the reason here, the main reason, nkuko bishushanije hangaha, ikibazo iyi enzyme yitwa MTP, microsomal triglyceride protein, it is not an enzyme. Normally it is the one from which we have this protein. Ariko ikindi hari subunits ahangaha igomba gukora ibyo byerekana B48, B100 and so on. So nyango ni indwara, personally I have not seen it. I don't know if we have them in Rwanda, but diagnosis should be through biochemistry or clinical chemistry rather than pathology itself. Ariko ikizayiranga ni iki, the clinical signs and the symptoms of malabsorption. Ashobora kujya n'ibya steatorrhea n'ibindi bijyanye nabyo. So we end this part of small intestine with carcinoid tumors. Nazivuzeho kare mu gitondo tuvuga carcinoid cardiac disease. So there are tumors arising from neuroendocrine cells. They can be low grade, they can be high grade malignancies. So they can arise anywhere in the gut. Ahanga harimo neuroendocrine cells anywhere they are. muri small intestine ziba ziriho ahantu hose buriya zivangavanze na enterocyte. So they grow as a submucosal polyp like tumor, a nodule. Ku buryo kenshi bakoze endoscopy uba endoscope iba ukwisunika wumva ko inyuma hari ikintu ariko ntubukibona kuko ko iri inyuma ya mucosa. So they secrete serotonin, yango serotonin twayibonye kare, ikibazo cyayo it can be metabolized by the liver and so on, ariko ikintu twabonye kare nuko akenshi igira effects on the right heart, then iyo yoherejwe muri lungs nibwo iba well catabolized ku buryo nta bindi bibazo zongera gutera. Ariyo mpamvu right heart is more endangered by these carcinoid tumors. But we can have a metastasis of carcinoid tumors to the liver bituma ya serotonin nuba ko liver y'ubwayo ifite ubushobozi bwo gukora catabolization of the serotonin hitera ibibazo umutima. Birumvikana ni igihe carcinoid tumor iri ahantu bituma serotonin ikoze ihita inyura ku mwijima, kandi ntabwo byose ibintu binyura ku mwijima. Inyura ku mwijima bivuye muri gastrointestinal tract. Niba carcinoid tumor iri ahandi kure ntabwo izabanza muri liver, amaraso azaza bwa mbere anyure muri right heart. So I think the signs and the symptoms here: diarrhea, flushing of skin, bronchospasm. Don't need to repeat it. So the primary carcinoid tumors nuko zitari metastatic zishobora kuba hano henshi rero. Hari ibihaha, nk'iyi ni yerekana imibare yabonetse ahantu hamwe muri center imwe, ariko inyinshi ushobora kubona ko yavuye muri midgut. Ari no mpamvu midgut murabizi ni small intestine hariya. Hintergut ni igice kijyanye na colon iheruka hasi. Hintergut, I think you remember this in embryology. So midgut niho inyinshi babonye zaturukaga. So akongeraho iza pancreas nazo ni nyinshi, then izo muri lungs nkeya, stomach imwe, esophagus imwe and so on. So byumvikana ko niba ari tumors zaturutse ahandi hantu aho amaraso ava atanyura muri liver, carcinoid syndrome izahijya ku mutima kubera ko serotonin was not catabolized by the liver first. So appendix, ngira ngo turi kugenda anatomically uko izi organs zikurikirana. So before going to the colon, we first go to the appendix. Appendix ikikunda kuyifata ni appendicitis. They are very frequent in Rwanda. So uwari wese baba abantu ba middle age baba bakuru cyane barayigira. So iterwa n'ibintu bitandukanye. Hari ibintu bikunda kujyamo bikitekeramo mu gihe stool ziri kumanuka, hakagira ibijyamo. Rimwe na rimwe bavuga ngo nta mabuye, nk'umuntu arya ibintu bimwe amabuye bijyamo. Yes, it can be a risk factor, but ntabwo buri gihe muri appendicitis usanga muri mutuye, ntabwo ari kenshi tuyabona. So it is frequent. Nyango kera in medical school umuganga agomba gusohoka mu ishuri, hari ibintu by'ingenzi yabaga azi kubaga. Hari gukora cesarean section, hari gukora kubaga umuntu wagize appendicitis agakuramo appendix, hari no gukora hernia, mu gifaransa bita herniorrhaphy. Umuntu wagize hernia no kuvuga intestine zikamanuka nko muri inguinal area, sometimes in scrotum, kumenya kuyibaga. So yari ibyo bintu bitatu. Nowadays I don't know. So meaning that this is a critical thing. So kuzohereza umurwayi akava muri district hospital akoherezwa CHU cyangwa CHB ku appendicitis, ntabwo bisona neza. Ntabwo bisona neza kubera ko muri district hospital ni ikintu wagombye gukora. So reasons, causes zayo ziratandukanye, so they are presented here. But clinical signs, ikintu nanone kindi ushobora kuba blamed ni igihe umuntu azaba aribwa ahantu right lower abdominal quadrant. Muri differential diagnosis zawe ntushyiremo appendicitis, ntizi imbere mu bindi. zaba ari ikibazo gikomeye. So iyi bayita okay, Mark Brune point de Mark Brune iri aha ngaha. So it is just below the umbilicus but on the right side on appendix. So umuntu uje aribwa hariya, ikintu cya mbere ugomba gutekereza ni appendix. So hari abantu bake bagira appendix zabo zitari hariya, ziri ahagana inyuma cyangwa ahagana hejuru. Iyo if you miss that, nobody, nta muntu uzakurenganya. Ariko if it is a classical one and you miss it, it will be a big issue. So the inflammatory bowel diseases, they are of two types. So we have Crohn's disease. It is written somewhere. Yes, Crohn's disease and ulcerative colitis. So hano nashyizeho diagrams ebyiri zibyerekana. Ikintu kiziranga cya mbere na mbere nuko Crohn's disease ifata, sorry, let's start with colitis. Ulcerative colitis ifata colon gusa, ibyo birumvikana, kandi ifata igice kimwe ubwacu. Naho Crohn's disease ishobora gufata small intestine and the large intestine. So ntabwo iri limited kuri colon. Ikindi igihe cyo ita skipping regions. So irafata agace kamwe igasimbuka kandi akabazima ikongera igafata ahandi. So nuva ubaza umuntu ukabona afite ibibazo nk'ibi cyangwa so ukoze any other investigation ukabona afite, so skipping regions, a region here, then a normal part, another region. So think about Crohn's disease rather than the colitis niba ari biri muri colon. So I think that is the main difference. Otherwise here there's a table here. Yeah, you can just read. So the figures it deliver to the so you can look at the figures inside there. So any question about the small bowel before we end with colon? So just a few minutes so we end with this large intestine. So hari Hirschsprung disease navuzeho kare, iyo ni ikintu umuntu avukana ugereranyije na akarasia yo muri esophagus. So ni ikibazo cya ganglion cells umuntu aba adafite hano. So niyo mpamvu igaragara mu bana byinshi. So tuyibona muri Auerbach plexus, which is mesenteric, cyangwa se muri Meissen or submucosal plexus. Plexus ziba zihari, ni ukuvuga nerve endings, ariko wazera ukaburamo ziriya ganglion cells. So as I said, okay, this is normal way. So muri abnormal condition, then niba yagize ikibazo hagana hasi kuri hasi ariho hari ikibazo cya ganglion cell, ho hazaba ari constricted. So hazaba hari karibari ntoya cyane of the lumen, because the muscles can't relax. If the muscle can't relax, it will contract and obstruct the lumen. So consequence ya izagaragara rero nuko hejuru ya kwera ko ibi stools zagomba kunyura zizirundamo hari hazabyimba. So nibyo navuga n'abaganga bamwe na bamwe bakora amakosa akibwira ko hano habyimbye ariho hari ikibazo, kandi habyimbye haba hari normal cyangwa se hari cyo bita transitional zone, nuko harimo ganglion cells nkeya, ariko hafite ikibazo ni hariya hifunze hasi. So don't do the same mistake. Ufate ahabaye dilated kucheke koreho ikibazo kiri. So other diseases are diverticular. Nkaza senka diverticular twabonye aho haza additional pocket to the organ. So we have twinshi diverticular. If it is one diverticular, many diverticular. So complications zazo ni nyinshi, harimo kuba stools zajyamo cyangwa foods zageramo zikaba stagnant, zigatera inflammation. Another complication will be perforation, of course. So usually they are symptomatic. They will be symptomatic when there are complications in rectal bleeding, inflammation, fistula. It can here perforate. No perforation hane igahita itera inflammation to the surrounding tissue, tuvuge ni stomach, hakabaho fistula between let's say the transverse colon and the stomach, ko byegeranye n'urugero. So the irritable bowel syndrome ngira ngo ni indwara it is diagnosed by exclusion, aho usanga umuntu afite ibibazo mu nda gusa. Flatulence ni kuri umuntu aba afite ibigaze byinshi mu mara, bloating, amara yigorora yangwa yigoronzora and so on. Rimwe na rimwe akagira diarrhea, ubundi akagira constipation. So nibyo biri muri iyi diagram. So icyo gihe nta kintu kizwi cyitwa no identifiable pathologic changes. Ni ibintu gusa umubonaho rimwe na rimwe ugakeka ari psychological one. Ariko byagaragaye ko umuntu yafashe ibiribwa byo kurya birimo fibers, ni ukuvuga vegetables and fruits birafasha. So the colonic polyps, polyp twabibonye kare tubona kwituma ni akantu kaba kameze nk'agacuma kaba kari muri lumen of an organ. So it is the opposite of diverticular, wo izamo akoba kazamo additional pocket. Naho polyp yo ni akantu kanagana kari muri lumen of these organs. So it is a protrusion of colonic in the colonic mucosa. So ziza zifite impamvu nyinshi. So we have like here a sequence, we have a normal tissue, hyperplasia, then adenomatous polyp. No kuvuga harimo adenoma benign tumor but present itself like a polyp. Sometimes in it you can have a dysplasia then a cancer. So iki bivuga ko ibonye polyp ntabwo buri gihe bari benign, ushobora kuba cancer yanduka benign. So the pathologist is the one who will confirm if it is benign or malignant. So it is not up to clinician to decide here. Kubona imeze inyuma, no bleeding, it is the surface is irregular, then ugakeka ko ari benign ariko cancer irimo imbere. Then umurwayi amubwira gutaha ngo nta kibazo, bakazagaruka cancer yabaye ni itakibazo. So when then someone is having polyps, screening should be done by colonoscopy and fecal occurred blood test. Ni ikizami gikorwa bareba amaraso ari muri stools. Then if it is there, it is an indication that there is probably a cancer. Then your occurred blood test are positive, nibwo bashobora gukora colonoscopy. Akenshi ubundi banze kiri less invasive, then you go to more invasive colonoscopy, babonamo region, babonamo tumor, bagakora biopsy for confirmation of the disease. So hari abantu bagira icyo bita familial adenomatous polyposis, FAP, aho usanga afitemo a lot of polyps. So nigeze kwivugaho ko umuntu ashobora kugira polyp imwe, ebyiri, eshanu muri intestines, ariko baravuze bati nubona zishobora kuba zigeze ku 100, uwo muntu uzamenye ko afite familial adenomatous polyposis. So abafite inherited mutation in APC gene. APC means adenomatous polyposis coli n'ubundi. So no kwa ko birajyanye n'iyi syndrome. Ariko kwa ko tudashobora kuyitestinga ku muntu wese, iyo ubonye ari nyinshi nk'izi, you can confirm it is a familial adenomatous polyposis. So ko n'abandi bavukana cyangwa mu miryango bashobora kuba bafite ikibazo. So with this, there is the increased risk to develop some cancers, carcinomas, and so on. So there are the other polyps such as juvenile polyp, ni igaragara mu mwana w'imyaka itageze kuri 5, juvenile, otherwise isa n'izindi nuko iba yagaragaye ku muntu ukiri muto. Akaba n'iyi bita iyi syndrome, Jaeger's syndrome. So they have polyps throughout the gastrointestinal tract in many areas. So ntabwo ziba ziri hariya muri colon gusa no muri stomach bazibamo. Ariko ikindi kibaranga nuko urebye uruhu rwe, urebye mu kanwa ubonamo utuntu tw'umukara, utudomagure tw'umukara. So freckle-like spots in the lips or mucosa, genital skin. So this is autosomal dominant disorder, also it is congenital, as you understand. So these people, they have increased risk to develop a colorectal cancer, gynecological cancers and the breast cancers. It has been observed. So we finished with colorectal carcinoma. This is one of the most common cancers in Rwanda also, and even worldwide. One of kwisi bavuga ko ni ya gatatu mu cancer ziganje, ikaba ni ya gatatu mu cancer zitera impfu. So peak incidence 60 to 70 years, but so here we have to be very careful. Mu Rwanda kimwe n'ibintu ya East Africa, icyo nabonyemo nuko colorectal cancer iri mu bwoko bubiri. Hari ifata abana imyaka 20, ugasanga abana bafite imyaka 20, around 20 years, they have a colorectal cancer. Kandi bibirebye ni kanseri ku bana, kuri iyo ngiyo ifata abantu bato ibikora mucin, mu gihe ifata ikindi gice ibidakora mucin. Ikora mucin kandi iba no mu bato twasanze ifata igice cy'ibumoso. So the one graduate, our postgraduate student who graduated just this year, thesis ikoze kuri ibi ngibi. So twasanze abafite zikora mucin bakiri bato kanseri zabo zifata igice cy'iburyo cya intestines, ni ukuvuga hamwe ari ahegera in ascending colon cyane cyane n'igice cyonza cya transverse colon. Mu gihe abafatwa n'iyi ifata abantu bakuze bo iri right sided, harimo rectum. So therefore twaratekereje birashoboka cyane ko rero iri ifata abana iri genetically inherited somehow. So now we developed a research project. We want to test that, to do molecular testing that are not done in our country. So we are looking for funds. If we find funds, then we'll test if it is so. Ikindi tuteganya gukora nuko tuzakora screening yabo abagira icyo bapana nabo bantu, dore ko nabo bafite izo gene dukeka zigiri ibibazo muri abo bantu. Noneho turebe niba bafite no bagiye bagirwa inama yo kwisuzumisha abakiri bato, kubera ko protocole yo gusuzuma kanseri y'amara mu Rwanda screening nuko umuntu atangira kubikorera afite imyaka 40. Byumvikana babandi bafatwa bafite imyaka munsi ya 20 baba batakiriho. Niyo mpamvu dushaka nidusanga icyo kibazo gihe, kandi ntabwo ari bakeya, batari bakeya bafite ikibazo. Nidusanga n'abandi bo muri famiye zabo bafite ikibazo cy'ayo majene, so icyo tuzasaba leta nuko muri guidelines yo gukora screening hagira igihindurwamo tukavuga tuti ahari nidusanga hari umuntu wagize colorectal cancer akiri muto, aba bahuje bafitanye isano y'amaraso bo babe bakwemererwa wenda kugera kuri degree ya mbere cyangwa babe bakwemererwa kujya basuzumwa bakora screening bakiri bato nabo badategereje ya myaka 40. So it is what our intention. So carcino-embryonic antigen ni serum tumor marker iranga abantu bashobora kuba bafite colorectal cancer. So niho iyo azamutse mu maraso barayipima muri biochemistry labs tusashika n'ahandi. Bizamutse ni ikimenyetso ko umuntu ashobora afite colorectal cancer. Niba umuntu afite ibibazo abdominal, wakora wenda x-ray na endoscopy nimugira icyo mubona, mugakora test ukabona irazamuka, then can confirm, then ugakora surgery nubwo utazi aho tumor iri ukayishaka, nubwo wenda radio itayibona. So there is a sequence. Icyo navugaga tuzakora muri iyo study nuko iki microsatellite instability nicyo tuzadushakamo cyane cyane ikunda kuba kuri abantu bafite hereditary non-polyposis colorectal carcinoma. So ikindi rero ni staging, ntabwo twayigarukaho kenshi ariko twayibonye muri general pathology neoplasia. Staging of tumors, it follows the size and the site of the tumor. Na stage 1 ibikiri limited kuri mucosa, maybe a small part of submucosa. Ukwikura ikaba stage 2, yarenga serose, yamara gufata serose ikaba stage 3, yaba metastasized ikitwa stage 4. Byumvikana ko uko stage zamuka niko kuvura uyu muntu bigoye. Akenshi stage 4 abayize metastasis spread to other organs ntabwo abakivuwe with curative intent. So the treatment will be palliative, kumuherekeza. ntabwo azaba ari ukugira ngo akire kuko ntibiba bigishobotse iyo yagize metastasis. So ibi byose bisaba impamvu abantu biringirwa cyangwa bagirwa inama yo kwisuzumisha hakiri kare kugira ngo niba hari n'ikibazo kiboneke cy'igico agishobora kuvura. So that's all for this part. Any question? So if no question, then I have some questions here. To choose the best statement. So Crohn's disease associated with malabsorption, ulcerative colitis is a granulomatous disease. Okay, ibi ntabwo nabisomye ariko muri presentation birimo. So granulomatous disease muri izi zombi, Crohn na ulcerative colitis. Crohn's disease ni granulomatous, so this is B cannot be true. So ulcerative colitis has skip areas. So I explained something related to this. Yes or no? Crohn's disease is the limited colon or the above are correct. So which is correct among these ones? Anybody to answer?
Is D.
D.
It is D.
I think it is C.
C. Anybody else? So I think I explained very well that Crohn's disease is the one having skip areas. Isn't it? So Crohn's disease, it has skip areas. Igenda isimbuka hamwe akabazima ahandi akarwara ahandi akabakazima. So meaning that C cannot be true because it is the Crohn's disease which is has skip areas. So Crohn's disease is not limited to colon. It affects any parts of the gastrointestinal tract. Ulcerative colitis niyo iguma muri colon. So iki nacyo nagihakanye ko atari cyo. So nuwa kugisigaye ni cyo hejuru. Iki nacyo nigishobora kuba cyo kubera ko twabonye ko ari biri false. So Crohn's disease niyo it is associated with malabsorption, so it should be the correct answer. So ngira ngo birabyerekana niyo the correct one. So the second question. So about intestinal cancer and colorectal cancer, the pathogenesis occurs in this order. Hatangira metastasis, followed by infiltration, and lastly, there is dysplasia. The second, these cancers are rare in people who are more than 50 years old. C, raw fiber, high meat, and refined carbohydrates are risk factors from these cancers. Or both above are correct, or none of above is correct. So which is the best answer?
C.
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 Okay. Anybody else? Okay, so you are right. So C is correct. So these cancers, they increase in incidence as the age increases. So this cannot be true. B cannot be true. And the A cannot be true. Metastasis comes after. So it starts with dysplasia, then a tumor infiltration, metastasis comes afterwards. So C is the one which is true. So it changes its color. A third question about esophageal cancer. Most of esophageal cancer are located in the upper 1/3. Second, Barrett's esophagus is the risk factor to esophageal squamous cell carcinoma. C, HPV is not associated with esophageal cancer. And then, or are correct or none is correct. So what is the best statement here?
I think it is B.
D. Why?
No, B.
B.
Yeah.
Anybody else? ngira ngo ikintu agitinzeho Barrett esophagus ivuga ko haba intestinal metaplasia hariho serire zisa neza intestine kandi muri intestine ntabwo tugira squamous cell carcinoma, squamous cells, so therefore ntabwo twagira squamous cell carcinoma arising from glandular cells, so B cannot be correct. So C also cannot be correct because you have. I said that there are some cases. The former minister, study, or he was not yet a minister. So twabonye ko hari esophageal cancers which are associated with HPV, even here in Rwanda. So hasigaye A. Is it correct or not? Otherwise, niba itari correct ubwo itayisigaye ni E. So E is the most correct. So the most of esophageal cancers are not located in the upper third. So they are located in the middle for squamous, and then in the lower third if they are adenocarcinoma. So choose the best. The favored location or site of gastric cancer is the lesser curvature of the antropyrotic region. Gastric carcinoma is classified based on the depth of invasion, microscopic growth pattern, and histological type. For rural classification, we have intestinal and diffuse type gastric carcinoma. All the above are correct, none is correct. What is the best answer as a best statement?
D.
D.
I hope it's D.
Okay. So you are correct. So all these above three statements are correct. Fifth. So someone, a man aged 41, had a history of drinking 2 liters of whiskey per day in the past 20 years. He had numerous episodes of nausea and vomiting in the past 5 years. He experiences a bout of prolonged vomiting, followed by massive hematemesis, vomiting the blood, of course. On a physical examination in the emergency room, he had vital signs of normal temperature, a pulse is increased, respiratory rate is a bit increased, blood pressure is low, 80/40, so it is quite somehow low. His heart has a regular rate and rhythm with no murmurs in his lungs. Okay, the lungs are clear to auscultation. There is no abdominal tenderness, or distension, and the bowel sounds are present, so no acute abdomen. So his stool is negative for occult blood. Which of the following is the most likely diagnosis? So occult blood, nobody negative. It can show that adafite cancer in colorectal. So gibisigaye ni ibihe rero. What would be the diagnosis?
It can be esophageal laceration.
Laceration. Okay. Yes, any other person? Okay, so we are correct. It is B. I think it changed the color a bit. B is black here compared to others. So the 6th question, so we have 7 questions. So the 6th question, a 50-year-old man has noted a slowly enlarging lump in the left side of his face for 5 years. Physical examination, the famous subcutaneous mobile mass anterior to the left ear, and above the angle of the mandible. Remember, there's a tumor we mentioned which affects there. The mass is removed and is grossly 3 centimeters in diameter with discrete borders and gray-white cut surface. Microscopy, it has epithelial elements and a matrix of mucoid, myxoid, and chondroid tissue. Around the mass are serous glands. Okay, ngira ngo no gukopeza birimo hanga serous gland, then you understand which gland. Which of the following is the most likely diagnosis? Warthin tumor, adenoid cystic carcinoma, pleomorphic adenoma, mucophthalmoid carcinoma, or it is just a adenitis inflammation? What is the answer? Sorry?
C.
C. Okay.
C.
Okay, thank you. So it is pleomorphic adenoma, niyo ikunda kuba icyambere. Pleomorphic twabibonye muri chapter on neoplasia, ni imwe muri tumors zitari monomorphic. So it has both epithelial and mesenchymal component. Nkuko hano ifitemo nka cartilage, ifitemo fibrous, and then ikagira epithelial. Ikindi nakwiri muri uko bahadekirije hangaye twabonye ikunda gufata muri the angle above the angle of the mandible ni pleomorphic adenoma. Kandi ibi serous gland hano bavuze ni parotid, so niho ikunda gufata hariya. So I think you see that it change color. So the last question, a 49-year-old man has used chewing tobacco for the past 25 years. He goes to his dentist for a routine examination. I think those doing dental surgery, they will have to answer. On a physical examination, there are several 0.5 centimeter white plaques on the oral mucous membrane, just lateral to the left lower teeth. These plaques cannot be removed by scraping. I think I mentioned this very well in the presentation. This man is at great risk, greatest risk of developing which of the following conditions. So ubwo birasaba kumenya ni iki afite, then ni iki bishobora kuzamutera mu isi iri imbere. Someone to answer? Okay, mwese mwagiye.
Tunaniye.
No.
Habananije iki?
I think
Okay.
is number D.
B.
Is A.
A. It's A.
A can't be.
D lecture.
D. So ngira ngo icyo ubanza gusubiza bwa mbere uko utagisubiza aha ni uburwayi afite n'ubuhu bundi ahangaha, kugira ngo tumenye icyo byazamutera kera utavuga. So plaques that cannot be scrubbed, donc udashobora kuvuvunuraho, zanga wenda zisa n'umweru cyangwa zitukura wenda amakopesi.
Leukoplakia.
Yes, good, very good. Leukoplakia. So leukoplakia is a risk factor to what? So it is a risk factor to cause dysplasia and then squamous cell carcinoma.
Yes.
So the one which is D is right. So birumvikana ko icyasabaga
Yes.
gutekereza guconnect ibintu ntabwo ari ukusubiza direct, no gutekereza ibindi. So thank you very much for bearing with me. So koresha amasaha menshi ariko nta kundi. So see you next week. There are many things happening next week, so we will communicate and know how we will proceed. So otherwise, I thank you very much.
Thank you.
Thanks, lecture.
Yes.
Nice weekend lecture.
Okay, the same to you. See you next week.
See you.